chapter is salivary gland pathology. In this, we're gonna start with non-neoplastic diseases, and then we shall discuss the salivary gland tumors. So first is mucocele, the most common non-neoplastic disease of the salivary gland. As the name suggests, mucocele means mucin-filled cavity. Okay. Now, this is a common term for two different entities. One is mucus extravasation phenomena, whereas the other is mucus retention cyst. Mucus retention cyst. Clinically, they both appear the same, but their etiopathogenesis is different. Mucus extravasation phenomena results due to any tear in the salivary gland duct. Hence, there is extravasation of the mucin, and this mucin is pooled within the surrounding glandular tissue. Basically, this is a pseudocyst, and on the contrary, mucus retention cyst is a true cyst, wherein the pool of mucin is been surrounded by true epithelium, that is the ductal epithelium. Okay. So clinically, this appears as a dome-shaped swelling, which is soft, and the most common site is for either types is lower lip. Okay, it can be seen over the palate, tongue, buccal mucosa, floor of the mouth, but the most common site is lower lip. The more the superficial the lesion is, the more bluish or translucent cast is seen. The more deeper lesion, the color and the surface appearance are those that of normal appearance. Okay, normal mucosa color will be reflected if the lesion is more deeper. Okay. Coming to the histopathology of the mucocele, in mucus extravasation phenomena, as we could see, this is mucin filled cavity, and this is lined by not epithelium, rather compressed connective tissue. Okay, as you could see in this higher magnification, this area has been focused here. Okay. So this is not epithelium, rather this is compressed connective tissue. So since no epithelium is present, hence this qualifies for a pseudocyst. Okay, whereas on the contrary, mucus retention cyst, as you could see in this picture here, the cystic cavity is lined by epithelium. This is epithelium. The source of epithelium is coming from the duct itself. So this is ductal epithelium, and this is cystic cavity. Since cystic cavity is lined by epithelium, this qualifies for a true cyst. Okay. If nothing is specified, we take it for granted that mucocele is mucus extravasation phenomena, because mucus extravasation is far more common than mucus retention cyst. Okay, based on the incidence, mucus extravasation phenomena is more common than mucus retention cyst. Next is ranula. Ranula is basically a form of mucocele which is present in the floor of mouth. A form of mucocele present in floor of mouth. Okay. Since its appearance, it looks like frog's belly. So frog is Rana tigris. From there, the name has come as ranula. That's a form of mucocele that is present in the floor of the mouth, and such swellings are usually lateral to midline. They are not present right in the center. They are lateral to midline. A special type of ranula which is seen in the neck. What happens sometimes, this swelling, it dissects through the mylohyoid muscles. The swelling or the mucocele dissects through mylohyoid muscle. Thus, it presents as a swelling in the neck. So, this swelling in the neck is now called as plunging ranula, or since it is present in the neck, it is also called as cervical ranula. Okay. Plunging ranula or cervical ranula means one and the same thing. Next is hyalolithiasis. Basically, it's a stone present either in the gland or in the duct. The most common gland or the duct to be associated with hyalolithiasis is submandibular gland. We know that the submandibular gland, reason why it shows maximum incidence of hyalolithiasis is mainly two important reasons. The saliva produced by submandibular gland has got high mucin. Because of this increased mucin, the saliva is more tenacious. It binds to the foreign particle very easily. And moreover, the duct has got very long and tortuous course. Okay. Since the flow is going in the anti-gravitational direction, so there is more stagnation of saliva, more chances of forming cyaloliths. So clinically, one could see that they are hard on palpation. Usually the method used for palpation is bimanual palpation, okay, wherein we use one hand extraorally to stabilize the gland and the other hand is used intraorally to palpate the stone. Okay, the best radiographic view used is occlusal radiograph to observe the cyaloliths in submandibular gland. Okay, occlusal radiographs are used. Okay. Next is cyalidinitis. As itis means any inflammation, so cyalidinitis is basically inflammation of the salivary gland. Inflammation of the salivary gland is called as cyalidinitis. Now, this inflammation, it could be either because of any infection or non-infectious reason. Now, infection could be bacterial, viral, or fungal. The most common viral infection of the parotid gland, as shown in the picture, most common viral infection of the parotid gland is mumps. Okay. Most common viral infection of the parotid gland is mumps. Next is Sjogren's syndrome. The most common autoimmune disease of the salivary gland is Sjogren's syndrome. It is the most common autoimmune. Autoimmune means immunity against the self. Most common autoimmune disease of salivary glands. Okay. Now, Sjogren's syndrome can be either primary if it is only dry eyes and dry mouth, also called as Sika syndrome, dry eyes, dry mouth. Now, if the patient has got any other autoimmune disease other than these two, then it will be called as secondary Sjogren syndrome. For example, apart from Sika syndrome, that is dry eyes and dry mouth, if a patient has got any other autoimmune disease like rheumatoid arthritis, SLE, or scleroderma, then it will be called as secondary Sjogren syndrome. Okay. Now, histopathologically speaking, in Sjogren syndrome, being an autoimmune disease, there is infiltration of lots of lymphocytes. So these lymphocytes basically destroy the entire architecture of the gland. They destroy the normal architecture of the gland. Since the entire gland is destroyed, hence clinically it manifests as xerostomia, reducing the production of saliva, or dry eyes, reducing the production of tears. Few remnants of the gland are left behind. These remnants are called as epimyoepithelial islands. These are called as epimyoepithelial islands. Okay. Now, to identify a case of Sjogren syndrome, a diagnostic criteria has been set. According to this diagnostic criteria, there are 6 parameters. The first 2 parameters are basically symptoms, ocular symptoms and oral symptoms. That is dry eyes and dry mouth. Now, simply the presence of dry eyes and dry mouth are not taken as positive symptoms. The duration is important. Dry eyes for more than 3 months or dry mouth for more than 3 months is counted as a positive symptom for Sjogren syndrome. To check for these symptoms, few tests are performed. For example, ocular signs. Tests performed to check for dry eyes. The first test is called as Schirmer's test. Now, in this Schirmer's test, we use Wattmann's filter paper and we see how much amount of filter paper has become wet in a stipulated period of time. If it is less than 5 millimeters in 5 minutes, then we will say that this test is positive. Okay, that means there are dry eyes. Or the second commonly used test is Rose Bengal test, wherein Rose Bengal dye is used to see how much amount of destruction has already taken place. If the spread is less than, the score is less than 4, then we'll take that the Rose Bengal test is positive. Okay. Similarly, to see for oral signs, we perform Either we check for unstimulated salivary flow is exists. If unstimulated salivary flow is less than 1.5 milliliters in 15 minutes, then we count this as for dry mouth. Or we can perform a cyalography. Typical patterns are seen in cyalography. They are called as cherry blossom pattern. Cherry blossom pattern, which is also called as branchless fruit laden tree pattern. Branchless fruit laden tree pattern. It has also been compared to an apple tree pattern. Okay, apple tree pattern. Recently, another functional test has been added to this list wherein we used radioactive dyes. This is called as scintigraphy. Okay, so either cyalography, scintigraphy, or one can check for unstimulated saliva flow. Now, this is the radiographic picture showing specific cherry blossom pattern. Cherry blossom pattern is observed in Sjogren syndrome. Okay. Histopathologically, two important things to be remembered. The site of biopsy is preferably lower lip. Okay. The site of the biopsy is lower lip, or we call it as labial mucosa, which should be clinically normal. Okay, it should be clinically normal. That means no destruction has taken place here significantly. Otherwise, we won't get to see any significant findings in the histopathology. And what do we observe in histopathology? When we examine the slide, we see in an area of 4 square millimeter, if there are more than 50 lymphocytes, then we'll say that this is one focus score. And if we get more than or equal to one focus score, then we say that the histopathology is positive. This implies that the histopathology is positive for Sjogren syndrome. In an area of 4 square millimeter, if there is collection of more than 50 lymphocytes, then we count that as focus score. And if there is more than one such focus score present in that entire slide, we'll count the histopathology as positive for Sjogren syndrome. Then the last is serological test. Serology means study of antibodies. Basically, what we study in Sjogren syndromes, these are anti-nuclear antibodies. Okay. So basically, two types of antibodies: anti-Rho and or anti-SSA means one and the same thing. SSA means Sjogren syndrome A, or anti-La, that is anti-Sjogren syndrome B antibodies. Okay. We detect these antibodies. These are basically anti-nuclear antibodies seen in Sjogren syndrome. Now, there is another thing to be kept in mind before we arrive at the final diagnosis. We need to exclude these 7 conditions before we arrive at the final diagnosis. These conditions basically they mimic Sjogren syndrome. For example, past head and neck radiation treatment, such patients will also exhibit xerostomia, but this is not because of Sjogren syndrome. Hepatitis C infection, AIDS, pre-existing lymphoma, sarcoidosis, graft versus host disease, and use of anticholinergic drug. This also causes dry mouth. Okay, so these conditions have to be ruled out before we arrive at the final diagnosis of Sjogren syndrome. The next condition is Mikulicz disease. This is very much similar to Sjogren syndrome. Schaefer clearly says that this is basically a milder form of Sjogren syndrome with same etiopathogenesis, milder form of Sjogren syndrome. The basic difference is in lots of other scientific papers, what I could find out is it's not given in Schaefer's, that Mikulicz disease usually shows improvement with the use of steroids. Such patients shows improvement with steroids, but such improvement is not seen in Sjogren syndrome. Not seen in Sjogren syndrome. And the second difference what I could find is that there is no cherry blossom pattern seen in Mikulicz disease. Rest everything is same. No cherry blossom pattern is seen in the cyalography. Okay. This Mikulicz disease is also called as lymphoepithelial benign lymphoepithelial lesion of salivary gland. Okay, benign lymphoepithelial lesion of salivary gland. This is why benign lymphoepithelial lesion of salivary gland, and this also shows the presence of epimyoepithelial island. Since rest everything is same, so this also shows the presence of epimyoepithelial islands histopathologically. Okay. The last non-neoplastic disease, not the last, the one is sialadenosis. This is basically non-inflammatory salivary gland enlargement. The size is increasing, but not because of inflammation. One thing to be remembered from here is leafless tree pattern is seen in the cialography. We have done branchless tree in Sjogren syndrome. Here it is leafless tree pattern. Okay, this comes to the last non-neoplastic disease, that is necrotizing cyalometaplasia. Now this is a locally destructive inflammatory condition wherein which is caused due to the ischemia leading to tissue infarction. The basic etiopathogenesis lies behind ischemia, which is ultimately leading to tissue infarction. Because of this tissue infarction, a cruciform type of ulcer is seen most commonly on the palate. Now this cruciform ulcer basically mimics squamous cell carcinoma. It mimics malignancy, isn't it? In the clinical picture, it looks like squamous cell carcinoma. The best part is that this resolves spontaneously. No treatment is required. The average healing time is approximately 5 weeks. Okay. Another interesting fact for necrotizing cyalometaplasia is that not only clinically, it mimics squamous cell carcinoma even histologically. What happens in this? The red ridges are proliferating in response to the inflammatory mediators, and they form interconnected networks in the connective tissue, such that once we take a tangential section like this, what we see is epithelial islands are present in the connective tissue. Epithelial islands in connective tissue are seen. This is what we see in squamous cell carcinoma also. But in squamous cell carcinoma, these islands are comprised of dysplastic cells. Okay, wherein in necrotizing cyalometaplasia, the cells are not dysplastic. They are not atypical cells. This is how we differentiate them from squamous cell carcinoma. Okay. Such a type of proliferation is called as pseudocarcinomatous hyperplasia. Pseudocarcinomatous hyperplasia. It can be seen in any inflammatory condition. Necrotizing cyalometaplasia is just one example. It is called as pseudocarcinomatous, or it is also called as pseudoepitheliomatous hyperplasia, means one and the same thing. Okay. Pseudocarcinomatous or pseudoepitheliomatous hyperplasia. Now coming on to the salivary gland neoplasms, the first one is the pleomorphic adenoma. This is the most common salivary gland neoplasm. Out of all benign and malignant taken together, this is the most common salivary gland neoplasm. And what type of neoplasm is this? Benign. Okay, so most common benign salivary gland neoplasm is also pleomorphic adenoma. In general, taken together, benign and malignant, most common salivary gland neoplasm is also pleomorphic adenoma. Now, the most common site for pleomorphic adenoma extraorally is parotid and intraorally is palate. So, since this is a benign neoplasm, so basically it is a slow growing, okay, and most of the times non-painful, but it keeps on growing. So, size can grow to many centimeters, such that involvement of the facial nerve leading to facial paralysis is very very rarely seen in this. Okay, now this pleomorphic adenoma histologically shows both epithelial components as well as connective tissue components. Now epithelial components are present either in the form of epithelial islands or they form ducts, whereas connective tissue components, they whereas connective tissue components, they could be either in the form of myxomatous areas or chondroid areas, cartilaginous like, or bone like osseous areas, or simply hyalinized areas. Okay, Now, since this has got the presence of both epithelium as well as connective tissue, so this is called as a mixed tumor. Okay, but recent theory says that all these components, they are derived from ductal reserve cells, either ductal reserve cells or myoepithelial cells. That means their origin is entirely epithelial. Hence, it is not a true mixed tumor, rather, it is a pseudo mixed tumor. Okay, this belongs to the category of pseudo mixed tumor because origin is from either ductal reserve cells or myoepithelial cells. Okay, so histologically, we could see either the presence of duct as shown in this picture. Sometimes the duct shows presence of eosinophilic coagulum. You could make out this ducts have got eosinophilic coagulum in them, and they are surrounded by hyalinized areas. These are hyalinized areas. Homogeneous eosinophilic areas, these are called as hyalinized areas. Presence of cells which attain the morphology of plasma cells. These cells are called as plasmacytoid cells. They look like plasma cells, hence they are called as plasmacytoid cells. If you remember, plasma cells, they are the ones which have got eccentric nucleus. So such tumor cells are seen in pleomorphic adenoma, which are called as plasmacytoid cells. Okay. Other than this, myxomatous areas can be seen. Myxomatous means which has got lots and lots of mucoid material in it, such that the cells are very loosely arranged. The ground substance contains lots of amount of mucoid material. If the vacuolar degeneration takes place, vacuolar degeneration of cells takes place, then this leads to chondroid areas, cartilaginous areas. Okay. Or it could also present in the form of bone-like areas which are called as osseous areas. All these can be seen in one tumor. Many morphologies, many means pleo. Hence it is called as pleomorphic adenoma. Okay. Pleomorphic adenoma. Okay. Adenoma means a benign salivary gland neoplasm. Moving on to the next important benign salivary gland neoplasm, that is Warthin's tumor. This is also called as adenolymphoma. Almost exclusively seen in parotid gland. Okay. The pathogenesis says that it gets its origin from heterotropic entrapment of salivary gland tissue. Heterotropic salivary gland tissue in paraparotid lymph nodes, the lymph nodes which are surrounding the parotid gland. Paraparotid lymph nodes. Okay, so what happens in the adult life? This entrapped salivary glandular tissue, it proliferates to form the Warthin's tumor. This tumor has got very high association with smoking. It says that smokers, this is the only salivary gland neoplasm to has got association with smoking. Smokers have eightfold high risk eightfold high risk of developing this neoplasm as compared to non-smokers. Okay, eightfold high risk. Now, histologically speaking, this is called as papillary cyst adenoma lymphomatosum, wherein the tumor shows papillary projections. These are papillary projections. One, two. Okay, these papillary projections, they are projecting into the cystic lumen. This is the cystic space. This is the cystic space, and this papillary projections, their core is made up of lymphocytes. Hence, it is called as papillary cyst adenoma lymphomatosum (PCL). Okay, and once we take an aspirate from the cyst, we get a chocolate brown colored aspirate. Okay, chocolate brown colored aspirate is found in Warthin's tumor, chocolate, and such patients, since lots of lymphocytes are present, such patients, they are prone to develop lymphoma. They are prone to develop lymphoma. That is why it is also called as adenolymphoma. Adeno word is for salivary gland. Even Sjogren syndrome patients, they are prone to develop lymphoma. Two salivary gland pathologies, one is Warthin's tumor, other is Sjogren syndrome. Such patients, they develop lymphomas. Okay. Next is mucoepidermoid carcinoma. Now this is the most common malignant salivary gland neoplasm. Most common malignant salivary gland neoplasm. The most common site, again similar to pleomorphic adenoma, extraorally is parotid gland and intraorally they are seen in palate. Now since it's malignant, so they are rapidly growing, usually painful, and facial nerve involvement is very common, leading to facial paralysis. Okay, that is commonly seen, right? Now, histologically speaking, mucoepidermoid carcinoma can be classified as either low grade, intermediate grade, or high grade. This grading is basically done on the basis of how much the architecture of the neoplasm, whether it is cystic or solid. The more cystic it is, the more low grade it will be. The more solid it is, the more high grade. The cellular atypia, how much dysplastic cells are present. If the cellular atypia is least in low, cellular atypia will be highest in the high grade. And relative proportion of mucus cells, epidermoid cells, as well as the third population is intermediate cells. Okay. For example, a low grade tumor will show more cystic spaces, will show less cellular atypia, and will show more number of mucus cells. Whereas high grade will show more solid islands, more cellular atypia, and more number of epidermoid cells. Okay. Prognosis for high grade is worst among the three types, whereas prognosis for the low grade is good among the three types. Okay. Moving on to the next important malignant neoplasm, that is adenoid cystic carcinoma. Previously it was called as cylindroma, but now this term has been dropped. This represents some pathology of the skin. Okay, tumor of the skin adnexa. So that is why this term has been dropped. Now adenoid cystic carcinoma is most commonly seen in the palate, almost 50% cases. And extraordinarily, again, the most common site is parotid. Since it is malignant, so hence facial nerve involvement is very common. Facial nerve paralysis is commonly seen. Now, this tumor has got a very interesting fact to be remembered, that this invades the nerves and it spreads through nerves. It has got the ability for perineural invasion or perineural spread. It travels through the nerves to the other sites. Okay, perineural invasion, it invades into the nerves and it spreads through the nerve. Special features seen. One more tumor which can show perineural invasion other than adenoid cystic carcinoma, that will be our second preference, is polymorphous low grade adenocarcinoma. Okay, polymorphous low grade adenocarcinoma is the second choice. First tumor to show that is adenoid cystic carcinoma. Now, histologically speaking, three important patterns are seen in adenoid cystic carcinoma. The first pattern is cribriform pattern. Cribriform pattern means the one which has got lots of cystic spaces. Because of these spaces, this has been compared to Swiss cheese pattern. So where do you get to see Swiss cheese pattern? It is cribriform pattern of adenoid cystic carcinoma. The second less common pattern is tubular pattern, wherein the tumor cells are arranged in the form of tubules. Okay, and even more rare pattern is solid pattern, which is wherein the cells are arranged in the form of islands. Okay, since more number of cells are present in solid, it is present in form of islands. Cystic spaces are very less. So this solid pattern, it is highly aggressive. Okay, it is highly aggressive and it is associated with worst prognosis. It is associated with worst prognosis. The most common pattern is cribriform pattern, that has got a better prognosis as compared to these histological variants. So this completes our salivary gland pathology. Thank you. Okay, the next chapter is odontogenic cysts and tumors. Let us discuss first the odontogenic cysts. Now, the word cyst has been derived from the Greek word kystis, meaning a sac or a bladder. Well, we all are aware about the world famous definition given by Kramer. Cyst is basically a pathological cavity, right? Pathological cavity which contains either fluid, semi-fluid or gaseous content, which may or may not be lined by epithelium. And if it is lined by epithelium, then we will call it as true cyst. If it is not lined by epithelium, then we'll call it as pseudocyst. Okay. Now, odontogenic cysts, they belong to the category of true cyst, wherein the epithelium, the cystic cavity is lined by odontogenic epithelium. So, the odontogenic cyst is defined as any cyst wherein the source of epithelium is coming from any part which is involved in development of tooth. Odontogenic means associated with development of tooth. It could be either a complete tooth germ, reduced enamel epithelium, epithelial cell rest of Melissus, that is nothing but the remnants of HERS, epithelial cell rest of Serrae, that are nothing but the remnant of dental lamina, or simply the basal layer of oral epithelium. If you remember, the tooth development starts when the basal layer of epithelium starts proliferating to form dental lamina. Okay. So any of these source, if this is forming one of the source for the lining of the epithelium, then we'll call that cyst as odontogenic cyst. Now, depending upon the tissue of the origin, these odontogenic cysts are further classified as if the cysts which are derived from the rest of Melissus are two, radicular cyst and residual cyst. The one which are derived from the reduced enamel epithelium are again the dentigerous cyst and its soft tissue counterpart, that is eruption cyst. And the one which are derived from the remnants of dental lamina, that is rest of Serrae, the OKC, gingival cyst of newborn, gingival cyst of adult, lateral periodontal cyst, and glandular odontogenic cyst. So depending upon which tissue is contributing the lining of the epithelium, whether it is coming from the remnants of HERS or whether it is coming from the remnants of dental lamina, we classify them as on the basis of tissue of origin. Similarly, what is making this epithelium to proliferate? What is the etiology? What is the stimulating factor? Whether it is associated with the process of development or it is associated with some inflammation. So all these cysts, dentigerous cyst, eruption cyst, OKC, gingival cyst of newborn and adult, lateral periodontal cyst, COC, glandular odontogenic cyst, they are considered as developmental odontogenic cyst. Whereas if the stimulus or the etiology is inflammation, as seen in radicular cyst, residual cyst, paradental cyst, or buccal bifurcation cyst, these are counted as inflammatory odontogenic cyst. Now, why these two classifications are important? Simply just go through these two classifications. This helps us in solving many MCQs. For example, let me ask you a few basic questions. First is, which is the most common cyst in the oral cavity? I hope everyone is quite aware of this fact. The most common cyst in the oral cavity is the radicular cyst, that accounts for approximately 65%. If the examiner asks which is the most common odontogenic cyst, here many students commit this mistake. Reading the word odontogenic, they jump on to dentigerous directly. That is wrong. The most common odontogenic still remains radicular cyst because it is a type of odontogenic cyst. The epithelium is getting its origin from odontogenic apparatus. Okay. If I ask which is the most common inflammatory cyst, this most of the students get right almost all the time. Yes, radicular cyst. So, which is the most common developmental cyst? Okay, if I ask which is the most common developmental cyst, now the answer will come as dentigerous cyst. This accounts for approximately 16 to 20%, 24% cyst in the oral cavity. If I ask which is the most common developmental odontogenic cyst, then also the answer will remain the same because dentigerous is odontogenic as well as it's a developmental cyst. But if I ask which is the most common developmental non-odontogenic cyst, look here, the word here non-odontogenic, the source of epithelium is not coming from odontogenic apparatus, but it is still developmental. Then the most common developmental non-odontogenic cyst is median anterior maxillary cyst, also called as nasopalatine duct cyst. This is basically an example of fissural cyst, which is seen in anterior maxilla. Okay. Now, so with this background, let us start with first the inflammatory cyst. The most common cyst in the oral cavity is the radicular cyst. Now, this radicular cyst is also called as periapical cyst. Since it is present at the apex of the root, it is also called as root end cyst. Okay. Now, one thing to be remembered, this cyst is always and always associated with non-vital tooth. No exception to this rule. Radiographically, this presents as a well-defined radiolucency. Okay, the word well-defined is the one that differentiates it from periapical abscess. That is ill-defined radiolucency. Okay, now radicular cyst or periapical cyst or root end cyst, this is basically an inflammatory cyst and also the most common cyst in the oral cavity. Histologically speaking, what do we see since this is an inflammatory cyst? So rete ridges are proliferating. Now this proliferating rete ridges in radicular cysts, they are arranged in arcading pattern. This is called as arcading pattern of proliferation. Where do you get to see arcading pattern? We see them in radicular cyst. Okay. Moreover, there are presence of cholesterol clefts seen in the tissue or cholesterol crystals. Okay, crystals will be seen in the fluid which is aspirated from the cyst. That will be seen in the fluid, whereas the clefts are seen in the tissue. Okay, cholesterol cleft or cholesterol crystals. Moreover, Rushton bodies are seen. Now, what are Rushton bodies? Basically, these are curvilinear shaped C-shaped, arc-shaped. These are the words we use them. Eosinophilic structures. Their etiology is not clear. And they are not only exclusively seen in radicular, they can be seen in any odontogenic cyst. They can be seen in dentigerous, they can be seen in even OKC or gingival cyst of newborn. But the most common, if asked to choose, our first preference will always be radicular cyst. Okay. So these curvilinear shaped eosinophilic, these are called as Rushton bodies. Okay. Now next is residual cyst. Residual cyst is basically found in absence of tooth when the pathology is left behind. Now this is histopathologically similar to radicular cyst. No change. Arcading pattern will be seen, cholesterol clefts will be seen, everything is same. Just that clinically there is no tooth. So absence of tooth, then we'll call it as residual cyst. If the tooth is presence of tooth, in that case we will call it as radicular cyst. Rest everything is the same. Okay, this is seen in the absence of tooth. Similarly, paradental cyst. Now paradental cyst is also an inflammatory cyst which is associated with partially impacted mandibular third molar. Partially impacted mandibular third molar, and it is always seen either on the buccal aspect or on the distal aspect of this tooth. And the associated tooth here, since it is inflammatory, but still the tooth associated is vital, it is not non-vital. So this is one cyst which resembles clinically and radiographically to the dentigerous cyst because it is associated with partially impacted tooth. But histopathologically, this is again similar to radicular cyst. A fact to be remembered, all the inflammatory cysts, whether it is radicular, residual, paradental or buccal bifurcation, they will have same histopathology, exactly same histopathology. Okay, so this is the radiograph showing a cyst on the distal aspect of partially impacted mandibular third molar. This is paradental cyst. Paradental cyst. The last in the inflammatory category is buccal bifurcation cyst. As the name suggests, again this is seen on the buccal aspect of mandibular first molar. Okay. This is mostly associated in the mandibular first molar where they present with buccal enamel projection or extension, means one and the same thing. So this is basically, this buccal enamel projection leads to periodontal involvement. Pockets are formed, and these periodontal pockets then ultimately the inflammation give rise to the buccal bifurcation cyst. So this is also histopathologically similar to radicular cyst. The associated tooth need not be non-vital, it may be even vital. Okay. Next are the developmental cysts. The most common developmental cyst in the oral cavity is the dentigerous cyst. The cyst is formed due to the accumulation of the fluid between reduced enamel epithelium and tooth crown. That means the tooth is impacted. It has not erupted. Hence, it is also called as follicular cyst. Follicular cyst is nothing but a dentigerous cyst. Okay, because of the accumulation of the fluid between the reduced enamel epithelium and the tooth crown. The most common site is mandibular third molar. This is the tooth which is most commonly impacted. After this, maxillary canine, then maxillary third molar, and then comes the mandibular secondary molar. Okay. Now, radiographically speaking, dentigerous cyst has got three variants depending upon the radiolucency with respect to the impacted tooth. It is classified as the central type, or the lateral type, or when the radiolucency covers the entire tooth, it is called as circumferential type. Okay, so in either of these three types, the cystic lining is always attached at cemento enamel junction. This is the place where reduced enamel epithelium is attached. So the cystic lining in all these three variants will always be attached at CEJ. This is something characteristic for dentigerous cyst. Okay. Now, histologically speaking, since the lining is derived from reduced enamel epithelium, so it is 2 to 4 layers thick. Okay, and it will resemble reduced enamel epithelium. So it is comprised of non-keratinized stratified squamous epithelium. Non-keratinized stratified squamous epithelium. Now, this long-standing dentigerous cysts have a potential to transform either into a benign odontogenic tumor, that is ameloblastoma, or malignant neoplasms like squamous cell carcinoma or mucoepidermoid carcinoma. Okay. Now, we say that this dentigerous cyst has transformed into ameloblastoma when it satisfies the Vickers-Gauling criteria. What is Vickers-Gauling criteria? When the basal layer of the dentigerous cyst, the cells of the basal layer exhibit nuclear hyperchromatism, darkly stained nucleus, and nuclear palisading with reverse polarization. Reverse polarization means nucleus is away from the basement membrane. This is basement membrane and the nucleus is away. And all the nuclei are at the same level. This is called as palisaded appearance. Palisaded means nuclei of the adjacent cells are at the same level. Since the nucleus has shifted away from the basement membrane, there is cytoplasmic vacuolization. This is subnuclear vacuole. Space is present. So these, if the basal layer shows this type of characteristic features, then we'll say that they are satisfying Vickers-Gauling criteria. Hence, this dentigerous cyst has transformed into ameloblastoma. Okay. Treatment for dentigerous, not only dentigerous, other most of the cyst remains the same. If the size is small, we go for enucleation. If the size is large, we go for marsupialization, followed by enucleation. We wait for the size to decrease and then we enucleate. And in case of multiple cysts, we can also go for jaw resection. Okay. Now, next cyst in this category is eruption cyst. Eruption cyst is basically a type of dentigerous cyst. We call this as a soft tissue counterpart of dentigerous cyst. Soft tissue counterpart of dentigerous cyst. When the tooth has erupted from the bone, but it has not erupted from the soft tissue. Rest histopathologically it is same, but it will not show any radiographic finding. No radiographic finding. Since it is not present in the bone, it will not cast any shadow. Okay. Once the tooth erupts out, it resolves on its own. Okay. Next is odontogenic keratocyst. Okay, see, this has always been in controversy. This is a tumor which is which has got high tendency for recurrence, very high rate of recurrence, very aggressive, and such that the Ki67 and PCNA indices are higher. What are Ki67 and PCNA? They are basically proliferative markers. Okay, so the value for Ki67 and PCNA indices was highest in OKC when compared to dentigerous cyst or radicular cyst, the other common odontogenic cyst. Okay, that is why researchers in the previous WHO classification that came in 2005, they named it as a tumor, keratocystic odontogenic tumor. But now again in 2017 WHO classification, this has been reclassified as cyst, OKC. Okay, this controversy is still persisting whether it is a tumor or whether it is a cyst. If the examiner counted as a tumor, the new name is keratocystic odontogenic tumor, or the new latest classification counts it, but that has come in 2017. Again, it counts it as a cyst, that is odontogenic keratocyst. Most common site for OKC is posterior body or ramus of the mandible. Similar to dentigerous cyst, OKC exhibit four radiological variants. The first variant is called as replacement type, as shown in the picture. Number one, replacement type means this is found in place of tooth. Rather than forming the tooth, a cyst is formed. So such a type of cyst is called as primordial cyst. Basically, what is primordial cyst? Primordial cyst is nothing but a type of OKC. This is a question very often asked. Second type is envelopmental type. Envelopmental type, wherein the cyst is covering the impacted tooth like an envelope. This is similar to the dentigerous site. Okay, dentigerous cyst. This is similar to the dentigerous cyst, wherein the cyst is covering the impacted crown. Okay. Third type is called as extraneous type, which is seen in an area which does not bear the teeth. For example, ramus area. Okay. It is found in non-tooth bearing area. Cyst found in non-tooth bearing area. For example, ramus. This is called as an extraneous type. The fourth type is collateral type, which is seen in between the roots of two adjacent teeth. Okay, this is the collateral type. This is envelopmental type, primordial cyst, that is also called as replacement type, and this is extraneous type. Now, histologically speaking, in dentigerous we did 2 to 4 layers, whereas in OKC there are around 6 to 10 layers thick. Epithelium is 6 to 10 layers thick, and the superficial surface shows corrugations, wrinkled appearance. Because of the keratin, the surface shows corrugations, corrugated surface. Okay, that is wrinkled appearance. Wrinkled appearance. Other than this, the basal layer of cystic lining, it's comprised of tall columnar cells, and the nuclei are again palisaded. These palisaded nuclei, they have been compared to row of tombstones, as shown in the picture. एक के पीछे एक tombstone has been placed, or it is also called as picket fence appearance. Picket fence appearance. Now, this row of tombstone appearance is not exclusively seen in OKC, it is also seen in pemphigus. We will do this again in skin pathology. This is also seen in pemphigus. And also the lining is getting detached from the underlying connective tissue. This makes the lining friable. The lining is getting detached from the underlying. This is the lumen. Okay, this is the cystic lining. It is getting detached from the underlying connective tissue. This is epithelium. This makes the lining friable. Sometimes there are presence of daughter cyst seen in the connective tissue. Daughter cyst or satellite cyst. Daughter cyst or satellite cyst are also present. Now, satellite cyst. What accounts for its high rate of recurrence is sum total of presence of satellite cyst or daughter cyst. The cystic lining is fragile and it is difficult to completely remove it from the bony surface. That is, some part of cystic lining is always left behind that causes recurrence. Or the size is so big enough that surgeon does not remove the entire lining intentionally. That is called as conservative surgical approach. This is to avoid pathological fracture. If the entire lining is removed, if the lesion is so big, the mandible will become hollow and it will fracture easily. So this is to avoid pathological fracture or to prevent undue trauma, to any important structure. For example, nerve or blood vessel is present. To save that, the surgeon undergoes conservative approach. So some lining is left behind. Later on, that lining forms the reason for recurrence. Another histological variant of OKC is orthokeratinized variant. This is called as orthokeratinized odontogenic cyst. Now, this variant was clinically not that aggressive. It was not aggressive. It had got very good prognosis. Okay, and it has recurrence rates are very low as compared to parakeratinized variant. Recurrence rates are very low. So it has got a very good prognosis. So this is still considered as a cyst and not as a tumor. So name of this cyst is odontogenic orthokeratinized cyst, OOC, whereas OKC has been renamed as KCOT. Okay, since this is an orthokeratinized variant, so this will show prominent, as shown in the picture, prominent granular layer will be seen. Granular cell layer will be prominent. This is the feature of orthokeratinization. Look at this. Sorry, this is prominent granular cell layer is seen. Look at this. This is prominent granular cell layer, and obviously the nuclei will show no nucleus. The cells will show no nucleus. Hence, it is called as orthokeratin. Whereas parakeratinized variant will show pycnotic nucleus. Moreover, the basal layer will not show tombstone appearance. It will not show row of tombstone appearance, or picket fence appearance is not seen. Picket fence appearance is also not seen. These are the major differences between OOC, orthokeratinized variant, and parakeratinized variant. Now, there is an important syndrome associated with multiple OKCs that is called as nevoid basal cell carcinoma syndrome. This is also called as Gorlin-Goltz syndrome. Also, in short, we call this as Gorlin syndrome, means one and the same thing, but Gold syndrome is something different. Okay, so this is characterized by multiple also in short we call this as Gorlin syndrome, means one and the same thing, but Gold syndrome is something different. Okay, so this is characterized by multiple basal cell carcinomas of the skin, as well as we could see one, two, even here also it is radiolucent, here also it is radiolucent, multiple OKCs. So this is associated with multiple OKCs as well as multiple basal cell carcinoma. Moreover, Palmer or plantar pits are seen. Important features: calcification of Fox as shown in the picture, or calcification pits are OKCs as well as multiple basal cell carcinoma. Moreover, Palmer or plantar pits are seen as shown in the picture, or calcification of Fox cerebri. These are the important features: calcification of Fox cerebri. Now, this syndrome is due to the mutation in the gene patched gene. Okay, now this is located on chromosome number 9q. Okay, 22.1 to 31. Just remember chromosome number 9q. Okay. Now, next is gingival cyst of newborn. These are called as gingival cysts of newborn. Seen in the oral cavity of the newborn, they appear as white keratin-filled nodules because their lumen is filled with keratin, hence they appear as white in color. After some time, they rupture and they resolve on their own. Okay, their source is from the remnants of dental lamina. Hence, they are also called as dental lamina cysts. The source is from dental lamina. This should not be confused with Epstein pearls. Epstein pearls are also counted along with the gingival cyst of newborn, but they are entirely different entity. They are seen along the mid-palatine raphe. Look at this picture. This is the mid-palatine raphe. One cyst here, one cyst here. So these are again keratin-filled nodules that appear as white as pearls. That's why they're called as Epstein pearls. Now these are not derived from dental lamina, rather they are derived from the entrapment of epithelium. Entrapment of epithelium, not the dental lamina. And one more brother in this category is bones nodules. Bones nodules, as Epstein pearls were seen along the mid-palatine raphe, bones nodules are seen along the junction of hard palate and soft palate. Okay, and their origin is again not from dental lamina. The origin is from minor salivary glands, glandular tissue, minor salivary glands. Okay, minor salivary glands. Now the next is lateral periodontal cyst. As the name suggests, this lateral periodontal cyst is seen in relation to the lateral surface of the root. Okay, lateral surface of the root. So the associated tooth need not be non-vital. Associated tooth is vital. It gets its, as the name suggests, it is lateral periodontal. It is getting its origin again from dental lamina. It is a developmental cyst which is getting its epithelium from dental lamina, and it is present in between the two roots. It is present in between the two roots. Hence it is called as lateral periodontal cyst. Most common site is mandibular premolar region. Mandibular premolar region. Now what is so special about this cyst? This cyst, histologically, you could make out this is the lumen, this is the cystic lining. Now the cystic lining at places shows focal thickenings. This is 1, this is 2. Same thing is shown in the higher magnification. This is something characteristic for LPC. It shows focal thickenings, also known as plaques. Okay. Now these focal thickenings can also be seen in botryoid odontogenic cyst. Now botryoid odontogenic cyst is nothing but plural form. Many LPCs, if they occur together, we call them as one botryoid odontogenic cyst. So it is a plural form of lateral periodontal cyst. Botryoid itself means cluster of grapes. Many grapes are seen together, wherein one grape is individually lateral periodontal cyst. So histologically, it is identical to lateral periodontal cyst. If one, then lateral periodontal cyst. Many lateral periodontal cysts occurring together, we will call that as botryoid odontogenic cyst. One more cyst which resembles lateral periodontal cyst is gingival cyst of adult. Now this is considered as the soft tissue counterpart of LPC. This is the soft tissue counterpart of lateral periodontal cyst. So it is exclusively seen in the gingiva, no radiographic image. Okay, and it ruptures and heals on its own after some time, unless and until it gets secondary infected. It needs special maneuver. Okay. Then is glandular odontogenic cyst. As the name suggests, it has the features of gland as well as the epithelium is odontogenic. So this is also called as cyalo. Cyalo word is for gland. Cyalo odontogenic cyst. Cyalo odontogenic cyst. And it is also called as mucoepidermoid cyst. Mucoepidermoid cyst, not the neoplasm. Mucoepidermoid cyst. Now, this glandular odontogenic cyst, it's clinically seen in mandibular canine or premolar region. It is not seen in molar region. It is seen in the canine and the premolar region of, most commonly seen in mandible. Now, this tumor, this cyst lining has got gland-like features. You could make out this clear cells. These clear cells, large clear cells, these are basically goblet cells. Because of the presence of these goblet cells, this cyst has gland-like features. What are gland-like features? Because of the goblet cells, it can perform the function of secretion. Okay, it produces mucin. Goblet cells releases mucin. Plus, it also has got the presence of focal thickenings, as we saw them in LPC. Focal thickenings similar to LPC are also seen. Okay, so these were the important points from odontogenic cysts. Now we move on to the next category, that is odontogenic tumors. Now the most common benign odontogenic tumor, we'll start with the first, the most common benign odontogenic tumor. Yes, your answer is right. It is odontome. Okay, some researchers believe that odontome is a hamartoma and not a neoplasm. For them, the most common benign odontogenic tumor becomes ameloblastoma. But for us and for many researchers, odontome is first, second is ameloblastoma. Okay, as odontome belongs to the category where there is a contribution of both ectomesenchyme as well as epithelium. So tooth or tooth-like structures are formed. So if the calcifications resemble the teeth, then we'll call it as compound odontome. If they do not resemble, then we'll call them as complex odontome. Okay. So if calcified structures resemble the teeth, supernumerary teeth are formed. This is called as compound odontoma. This is mainly seen in anterior maxilla, whereas if they do not resemble the tooth, the calcification are formed. There is formation of enamel and dentin in this also, but it is not properly organized. Hence, it is called as complex odontome. This is mostly seen in posterior maxilla. Okay, both odontomes are commonly seen in maxilla when compared to mandible. Now, moving on to the next important tumor, that is ameloblastoma. Ameloblastoma is defined as a true neoplasm of enamel organ type tissue which has not matured enough to the point of enamel formation. Okay, the 5 keywords given by Robinson to describe is that it is basically a tumor which is unicentric, non-functional, intermittent in growth, intermittent in growth, and anatomically benign, and but clinically persistent. So these 5 keywords describe the entire tumor. It has got one foci, one unicentric, non-functional, though it is growing but it is not performing any function, intermittent in growth, anatomically benign, and clinically persistent. Swelling is always evident clinically. Okay. Now the different types of ameloblastoma. Ameloblastoma is basically categorized under the first category of benign odontogenic tumor. That is, it has its origin only from the epithelium, no contribution from ectomesenchyme. Mainly 4 types of ameloblastoma were described. The conventional is solid multicystic ameloblastoma. Rather than forming many cystic cavities, if only one cavity is formed, we'll call this as unicystic ameloblastoma. This was solid multicystic, the conventional one. If only, rather than many cavities, if only one cavity is formed, we'll call this as unicystic ameloblastoma. Whether SMA or whether unicystic, if it is found in the soft tissue and not in the bone, we'll call it as peripheral ameloblastoma. And in the previous classification, the desmoplastic ameloblastoma was considered as the 4th type of ameloblastoma. Now, since let us start with the conventional type, that is solid multicystic ameloblastoma. As the name suggests, many multiple cystic cavities are found. So radiographically, it appears as multilocular radiolucent lesion. Now, this multilocularity, if the size of the loculations are small, this has been compared with honeycomb appearance. This honeycomb appearance can also be seen in pin box tumor or odontogenic myxoma. And if the size of the loculation is big enough, then this multilocularity has been compared with soap bubble appearance. Now both soap bubble and honeycomb appearance are associated with ameloblastoma. Now the resected specimen shows that this tumor is comprised of many cystic cavities. So histologically speaking, the most common variant is follicular variant. This is the most common histological variant of SMA. In this, follicles are formed. Big islands, follicles are formed wherein the periphery is lined by ameloblast-like cells. As you could see in this picture, these are ameloblast-like tall columnar cells. Ameloblast-like cells. Whereas the central cells are loosely arranged polyhedral cells. They resemble stellate reticulum-like cells. Okay. Because we did the definition, it is a neoplasm of enamel organ type tissue. In enamel organ also we see these structures, same structures we are seeing in ameloblastoma. Okay. Now the second, within the follicle, sometimes what happens, stellate reticulum undergoes squamous metaplasia. The cells, they change their morphology to squamous cells. This is called as squamous metaplasia. And what is the function of squamous cells? They form keratin in the oral cavity. So sometimes even keratin can also be seen. Okay, this is keratin. These are squamous cells. So such a variant of ameloblastoma where stellate reticulum undergoes squamous metaplasia is called as acanthomatous ameloblastoma. Now, rather than undergoing squamous metaplasia, if the stellate reticulum cells undergoes granular cell changes, their granular cell changes appear, then it is called as granular cell ameloblastoma. This is considered to be the most aggressive, highly aggressive variant. And what do these granules represent? These granules represent lysosomal aggregates. What is present in these lysosomes? These what are present in these granules? Basically, they are lysosomal aggregates. We know that lysosomes contain hydrolytic enzymes. That is why this is a highly aggressive variant. Okay. Now, follicles can also show basal cell changes. Basal cell changes means these are hyperchromatic cells. Often they are confused with basal cell carcinoma, but that is exclusively seen on the skin. Whereas basal cell ameloblastoma, we are talking about the central variant, which is seen within the bone. Okay. So this is called as basal cell ameloblastoma. Now, rather than forming follicles, if the odontogenic epithelium is arranged in the form of interconnecting cords, they form the network of interconnecting cords. Then it is called as plexiform ameloblastoma. So this is odontogenic epithelium. This is forming parallel cords which are interconnecting with each other. In between these cords, stellate reticulum-like cells are still present. Stellate reticulum-like cells are seen. Okay, this is called as plexiform ameloblastoma. The sixth histological variant is characterized by excessive fibrosis of the connective tissue leading to hyalinization. Okay, the connective tissue is getting hyalinized. Hyalinization of connective tissue ultimately leading to compression of the follicles, compression of the odontogenic follicles. Now, desmoplastic ameloblastoma has got many differences from conventional ameloblastoma. All other types of ameloblastoma, they are more commonly seen in men. This is the one type of ameloblastoma where men and female are equally affected. All other types of ameloblastoma are mostly seen in mandibular third molar region, whereas desmoplastic ameloblastoma is seen anterior to the molar region. That is, it is more commonly seen in the premolar region. All the ameloblastomas, they appear as multilocular lesion, whereas desmoplastic ameloblastoma gives mixed radiolucent or radio opaque appearance. Why radio opaque? Because of the desmoplasia, because of the hyalinization. Sometimes it shows haziness. So it is counted as a mixed radiolucent, radio opaque lesion. So since there were so many differences and prognosis for desmoplastic is poorest, it is associated with poorest prognosis. So the researchers thought that this is a special type of ameloblastoma, hence they classified it as the fourth type of ameloblastoma. Okay, fourth type. But according to WHO recent classification, which has not come in Schaeffer's, but 2017 WHO has released it, it has again taken desmoplastic ameloblastoma to the sixth histological type of SMA. They say that it is no special, it is one of the histological variants of SMA. Okay, so SMA has got six variants. First is follicular, second is acanthomatous, third is granular cell, fourth is basal cell, fifth is plexiform where network is formed, and sixth is desmoplastic where desmoplasia of the connective tissue is seen. Okay. Moving on to the next, unicystic. Rather than many cystic cavities, if only one cystic cavity is seen, as shown in the picture, only one cystic cavity, then it is called as unicystic ameloblastoma. Now, since only one cavity is involved, so this behaves like a cyst. Hence, it has got a very good prognosis as compared to the solid multicystic variants. It has got good prognosis. So treatment requires simply enucleation. We need not go for resection. Okay. Enucleation shows very good prognosis. Now, depending upon the type of proliferation of lining, if lining only along the lumen, then it is called as luminal type of unicystic ameloblastoma. If the lining is proliferating into the lumen, with the in the lumen, then it is called as intraluminal type. And if it is proliferating into the connective tissue, this is connective tissue capsule, this is lumen. Okay, then it is called as mural type of unicystic ameloblastoma. So three types of unicystic ameloblastoma: luminal, intraluminal, mural. Out of these three, mural has got the worst prognosis. This is as bad as SMA. So it should be treated with resection and it should not be treated with enucleation. Whereas luminal and intraluminal, they still behave like a cyst. So they can be treated with enucleation. Resection is not needed for them. Whereas mural, resection is needed. So treatment and prognosis, which type has got better prognosis? Unicystic has got good prognosis. It is treated via enucleation. Except which type of unicystic has got bad prognosis? Except for the mural type. That is an exception. Okay. Now moving on to the next odontogenic tumor, that is AOT, adenomatoid odontogenic tumor. Now this is also called as tumor of toes. Since this is commonly seen in second decade of life, maxilla to mandible ratio is 2 is to 1, whereas anterior to posterior ratio is also 2 is to 1. Okay. Moreover, male to female ratio, gender ratio is also 2 is to 1. So they said since so many twos are there, so then hence it is also called as tumor of twos. Now the name adeno means gland-like. So this tumor shows gland-like features as well as proliferation of odontogenic epithelium. So here the odontogenic AOT, most common site, it is associated with impacted canine. Associated with impacted canine. Okay. Histologically, it shows the formation of ducts. That is why it is called as adeno. The ducts, what you see in salivary gland, or sometimes rosettes are also seen. Rosette pattern, rosettes of epithelial cells, or convoluted pattern are also seen in AOT. Okay, mainly they are ducts. Ducts sometimes contains eosinophilic coagulum, or rosettes, rose-like pattern. The cells are arranged in rosettes, or convoluted pattern of cells are seen. Okay. That's all for AOT. Next is Spinbox tumor, that is calcifying epithelial odontogenic tumor, CEOT. This clinically mimics ameloblastoma, as well as radiographically it appears as multilocular radiolucent lesion, and clinical site is also same as that of ameloblastoma, that is third molar or ramus area in the mandible. But radiographically one can differentiate it because Spinbox tumor at times shows snow driven appearance. This snow driven appearance is due to the presence of calcifications. These calcifications, they are called as Lees-Gang rings. Lees-Gang rings, as shown in the true picture also. These are Lees-Gang rings. Apart from that, these calcifications, the tumor cells, they are large polyhedral cells, with hyperchromatic nucleus. Cell size is big and the nucleus is also hyperchromatic. Sheets of large polyhedral cells with hyperchromatic nuclei are seen in Pin-Box tumor. One more important histological finding seen in Pin-Box tumor is presence of amyloid-like deposits. They are not true amyloid, they are amyloid-like deposits. Okay. Moving on to the next, that is calcifying odontogenic cyst. Now this has been renamed into two categories. The cystic variant has been called as calcifying cystic odontogenic tumor, whereas the solid variant has been called as dentinogenic ghost cell tumor. Okay. Now COC, calcifying odontogenic cyst, it is also called as Gorlin cyst. Two important findings in this: calcifications as well as ghost cells. So these are the ghost cells. Ghost cells, basically, what are ghost cells? Their origin is still not clear, but many researchers believe they show only outline of the cell, no organelles. No organelles are seen, and sometimes these ghost cells undergo calcifications. Hence, it is called as calcifying odontogenic cyst. These ghost cells only undergo calcifications, and calcifications are seen in the connective tissue also. Okay, so calcifying odontogenic cyst, two things you need to remember: presence of calcifications and presence of ghost cells. Now, ghost cells are not pathognomic to COC. Ghost cells can be seen in many other odontogenic conditions. Let us enlist them. Ghost cells can also be seen in ameloblastic fibrodentinoma. If you remember the second category of benign odontogenic tumors, ameloblastic fibrodontoma. Okay, there are three lesions: ameloblastic fibroma, fibrodentinoma, and fibrodontoma. Those cells are not seen in ameloblastic fibroma, but they are seen in dentinoma and odontoma. They can also be seen in routine odontome, compound or complex. Plus, they are associated with calcifying odontogenic cyst, which is also called as Gorlin cyst. Okay. Next is odontogenic myxoma. This belongs to the third category of benign odontogenic tumors. That means it has its origin only from ectomesenchyme. This is purely ectomesenchymal in origin. No part is derived from epithelium. This tumor contains high amounts of hyaluronic acids. Because of this hyaluronic acid, it is very aggressive. It is very aggressive. It keeps on burrowing and burrowing and burrowing. Lesion in the maxilla often infiltrates into the maxillary sinus. Okay, so infiltration of maxillary sinus is very common. As the name suggests, myxoma. So myxomatous tissue is seen. This is myxomatous tissue, the one which is rich in mucins. Okay, myxomatous tissue. So hence the cells and the fibers, they are very loosely apart. Now, very important radiographic findings. Many questions come from odontogenic myxoma. Because of its aggressive nature, bone destruction is massive. So trabeculae are rearranged. They are either arranged in horizontal step ladder pattern, as shown in this picture. This is horizontal step ladder pattern, or sometimes we simply call them as multilocular radiolucent lesion. showing honeycomb pattern, honeycomb appearance. As shown in the picture, honeycomb appearance can be easily appreciated. Other than this, we use the terms sun ray appearance for them or sunburst appearance for them. Also, we use the term tennis racket appearance for them, okay, to describe the radiological findings in odontogenic tennis racket appearance. So many radiological findings: multilocular radiolucency, honeycomb appearance, horizontal step ladder appearance. This is horizontal step ladder appearance, tennis racket appearance, sun ray appearance, or sunburst appearance. All these appearances can be found in odontogenic myxoma. So this completes our odontogenic tumors as well. Thank you. Okay, the next topic is infections, mainly the bacterial, viral, and fungal. In this, we'll be focusing mainly on the oral manifestations of these infections, and also simultaneously we'll be covering allergic and immunological disorders of the oral cavity. So let us first begin with bacterial infections. First one is scarlet fever. Now, scarlet fever, this is a bacterial infection caused by group A beta hemolytic streptococci. This bacteria releases an erythrogenic toxin. As the name suggests, erythrogenic. This toxin is responsible for causing red colored rashes on the skin. Okay. Now these red colored rashes, because of this red color, the name has come as scarlet. Scarlet means red. These red colored rashes, they have got a very rough texture. The texture has been compared with the roughness of the sandpaper, and they have also been compared with sunburn, that is redness, with goose pimples, that is rough texture. Okay. Next important clinical sign which is seen in this is, especially in the areas where the skin is folded, within the skin folds or in the inguinal areas, these red colored rashes are called as pastia lines. Okay. These pastia lines are also associated with scarlet fever. Important oral findings, very pathognomic for scarlet fever, is appearance of strawberry tongue. Okay, strawberry tongue or raspberry tongue. Theoretically speaking, they say that initially the tongue is red and white in color, so it appears as that of a strawberry fruit. Later on, it becomes completely red. Okay, in the advanced cases, it becomes completely red, hence it has been compared with raspberry. But practically speaking, they both mean the same, strawberry tongue or raspberry tongue. The redness is because of the hyperemia of fungiform papillae. Okay, hyperemic fungiform papillae. The fungiform papillae gets engorged with blood. They are filled up with blood. Because of that, this tongue appears red in color. Do not confuse a strawberry tongue with strawberry gingivitis. Where do we get to see strawberry gingivitis as shown in the picture? Any guesses? Yes, strawberry gingivitis is seen in Wegener's granulomatosis. Okay, now Wegener's granulomatosis, there are gingival swellings present, and upon these swellings petechial hemorrhages are seen, which have been compared with the strawberry fruit. Okay, so it is Wegener's granulomatosis. Now, what is Wegener's granulomatosis? This is an multi-system disease which is characterized by this important triad. Three important signs which are seen in granulomatosis are necrotizing granulomas affecting the upper and the lower respiratory tract. Mainly, it affects the upper respiratory tract, disseminated vasculitis, and glomerulonephritis. Okay, so Wegener's granulomatosis, you may remember this important triad: necrotizing granulomas affecting the upper and the lower respiratory tracts, disseminated vasculitis, and glomerulonephritis. Okay. Next is tuberculosis. We know that tuberculosis is caused by Mycobacterium tuberculosis. Mainly two types, primary and secondary. See, oral tuberculosis is very, very rare. TB in the oral cavity is very, very rare. Primary means wherein the lesion starts in the oral cavity. Okay, it starts in the oral cavity, whereas secondary means it has started elsewhere in the body and From that site, it has reached into the oral cavity. Most common route is hematogenous. The bacteria, they travel via hematogenous route and then they cause infection in the oral cavity. Okay. Out of the two types, the one which is more commonly seen in the oral cavity is secondary type. Okay. More common form seen in oral cavity is the secondary tuberculosis. Now, the most common site involved in primary oral tuberculosis is gingiva, though primary is rarest. Okay, more common type of TB seen in the oral cavity is secondary tuberculosis. Most common site, the lesions are seen on the tongue, palate, lips, buccal mucosa, or gingiva and the frenulum. The most common site for tuberculosis, if asked in general, is tongue, followed by palate. And the most common clinical complication or the clinical signs seen in the oral cavity, it manifests in the form of ulcer. So tuberculous ulcer in oral cavity, these ulcers, these have got undermined edges. Okay, undermined edges, that means this undermine means something like this: the destruction is more once you go more and more deeper, the opening is smaller, and they have got a granulating floor. The floor often shows granulation tissue, and the most characteristic finding is they are highly painful, extremely painful. This is what differentiates them from syphilitic ulcers, chancres. These syphilitic ulcers, they are considered as painless unless and until they are secondarily infected. Okay. Important aspect from tuberculous ulcer other than their clinical finding is their histopathology. Histopathologically, characteristically, granulomas are formed. These granulomas, they are characterized by the formation of caseous necrosis in the center. Okay, this area of caseous necrosis is surrounded by special type of giant cells called as Langhans giant cells. What is so special about Langhans giant cells? These are multinucleated cells wherein the nuclei are arranged in horseshoe shaped. Okay, U-shaped arrangement or horseshoe shaped arrangement of nuclei. And other than this, modified macrophages which are called as epithelioid cells. These macrophages, they try to get rid of this bacilli, but they are unable to do so. So the changed morphology, these are nothing but modified macrophages. These are known as epithelioid cells. And these three type of structures, Langhans giant cells, caseous necrosis, and epithelioid cells, at the periphery they are surrounded by lymphocytes and fibrous connective tissue. Okay, as you could see, this is all fibrous connective tissue. This is one foci, this is one granuloma, this is fibrous connective tissue. Okay, and these blue dots, all these blue dots, what you can see, plenty of them are lymphocytes. So these are special type of granulomas which are seen in tuberculosis. To differentiate this from another granulomatous disease, that is sarcoidosis. Now this is characterized by formation of non-caseating. Caseating granulomas are not seen. Caseating means cheese-like. Okay. So this is sarcoidosis. The type of granulomas what we see in sarcoidosis are non-caseating type. Other important questions from sarcoidosis is sarcoidosis. There is an increase in the level of the enzyme angiotensin converting enzyme. Okay, ACE levels are increased ACE levels. Okay, angiotensin converting enzyme plus the giant cells which are seen in these granulomas, they show star-like crystalline inclusions. Star-like inclusions are called as asteroid bodies. Sometimes they also show calcified laminated concretions. Okay, laminated means something which is going like this. These are called as Schaumann bodies. So both Schaumann bodies and asteroid bodies can be seen in sarcoidosis. Another important diagnostic test for sarcoidosis is Quim-Silsbach test. Okay, Quim-Silsbach test is a diagnostic test for sarcoidosis. Now, a type of sarcoidosis which is called as uveo-parotid fever, commonly called as Hereford-Waldenstone syndrome. Now, this is basically a form of sarcoidosis. Okay, this is nothing but a type of sarcoidosis. Important triad involved in this is enlargement of parotid gland. That is why the name is parotid. UVO, UVA is related with the eyes. There is inflammation of the uveal tracts of the eyes, and cranial nerve involvement. Mainly facial nerves are involved. Okay, facial nerve paralysis is very common. Since parotid involvement is there, there are granulomas which are seen in the parotid gland, inflammation of the uveal tracts of the eye, as well as cranial nerves are involved. Mainly facial nerve paralysis is commonly seen. Okay. Next is syphilis. We know that syphilis is caused by spirochetes, that is Treponema pallidum. Now, two type of syphilis, mainly congenital syphilis and acquired syphilis. If the mother is infected, the baby can be born with a congenital syphilis. Acquired is further divided into three stages: primary, secondary, and tertiary. Many important clinical signs are seen from congenital syphilis. So let us discuss that first. In the congenital syphilis, the characteristic appearance of the face shows frontal bossing, as shown in this picture. The nose appears concave, and it has been compared with the saddle. So saddle nose, basically it reflects concave nose. Hypoplastic maxilla. It affects mainly the maxilla, hypoplastic maxilla, and because of this, there is relative prognathism of mandible. Relative prognathism of mandible. Okay. Other than this, parrot beak shaped convex nails can also be seen. Parrot beak shaped Parrot beak-shaped convex nails are seen in syphilis. Contrary to this, where do we see spoon-shaped nails? Spoon-shaped concave, that is koilonychia. They are seen in iron deficiency anemia. Okay. Opposite to this is convex nails, that is seen in syphilis. This is iron deficiency anemia. Next is important clinical sign seen is the anterior bowing of tibia, that is called as saber shin. Anterior bowing of tibia, tibia becomes convex. And painless inflammation of the knee joint, that is known as Clutton's joint. Clutton's joint. This is associated with knee joint. Painless inflammation of the knee joint. Other than this, what we see in the oral cavity, related to oral cavity, characteristic Hutchinson's triad. These are the dental findings, ear defects, and findings in the eyes. You can compare them with Mahatma Gandhi's three monkeys. Okay, dental findings, ear findings, and eye findings. What are they? Let us discuss them. In the oral cavity, what we get to see them as mulberry molars. Okay, rather than forming cusp, globular structures are seen in the molars. These are also called as Moon's molars, or they are also known as Fournier's molar. They all mean one and the same thing. Okay, and in the incisors, we see notched incisors. There is a notch you can make out in this picture. These are notched incisors, or peg-shaped laterals, peg laterals, or we also compare them with the screwdriver shaped incisors. Screwdriver shaped incisors. Okay, so basically their incisal third is constricting. Usually what we see that in the incisor, cervical third is constricting, but in this case their incisal third, they are peg shaped, okay, or screwdriver shaped. So this all they represent enamel hypoplasia. These are basically counted as hypoplastic changes. Okay, and in the eyes there could be interstitial keratitis and involvement of the eighth nerve. We call it as eighth nerve deafness. So this forms the Hutchinson's triad. Hutchinson's triad. The involved teeth in this are also known as Hutchinson's teeth. They are mulberry molars, peg-shaped incisors, or screwdriver-shaped incisors. They all mean one and the same thing. Okay. Moving on to the next important clinical sign in syphilis, that is raggedase. Now, what are raggedase? Basically, raggedase, they are the scars which are seen around the oral cavity. Scars seen around oral cavity are called as raggedase. They are also seen in congenital syphilis. Okay. Then important clinical sign is Higo-Minaki sign. Now this Higo-Minaki sign implies thickening of the clavicle where it is attaching with the sternum. So it is thickening of the sternoclavicular portion. Thickening of the sternoclavicle is thickened where it is attaching with the sternum. So this is called as Higo-Minaki sign. That was important from congenital syphilis. Now primary syphilis, we know that the characteristic lesion seen in the primary syphilis is called as chancre, which is seen at the site of inoculation. Usually they are painless unless they are secondarily infected. So once they are secondarily infected, they becomes painful. Okay. Now this chancres, they are highly contagious. They are highly contagious. They can show the presence of these spirochetes, but most of the times the result doesn't come out to be seropositive. Maximum seropositivity is seen in secondary syphilis. This is also highly contagious stage, highly contagious or highly infective. So seropositive results are seen in this stage. And characteristic lesions seen on the skin, macules or papular lesions are seen on the skin, and similarly in the oral cavity, characteristic mucus patches are seen. Okay, mucus patches in the oral cavity. Now another name for syphilis is Lewis. Syphilis is also called as Lewis. In secondary syphilis, it is seen in that in immunocompromised patients, the syphilis spreads to the entire body. That type of syphilis is called as Lewis maligna. Basically, Lewis maligna is called as the fulminating type of syphilis. Okay, wherein it spreads and involves multiple organs. It can go to the brain, can cause neurosyphilis. Okay, that is seen in Lewis maligna. Then is the tertiary syphilis. In the oral cavity, the characteristic lesions seen in the tertiary syphilis are gummas. Now these gummas, they appear as a nodular swelling and then they ulcerate. Nodular swelling and then they ulcerate. So this ulceration can lead to perforation of palate, as shown in the picture, perforation of the palate. And another important clinical sign, that is atrophic or interstitial glossitis. Atrophic or interstitial glossitis. This is considered as one of the pre-malignant conditions. So this can transform into squamous cell carcinoma of tongue. Remember, syphilis is counted as one of the pre-malignant condition. That is because of this atrophic or interstitial glossitis. Okay. Next important bacterial infection is actinomycosis. This is also called as lumpy jaw, as jaw swelling is seen in this. Basically, this is caused by actinomycosis israeli. The important bacilli which is involved is actinomyces israeli. Now, in this case, the swelling is usually associated with presence of draining sinuses, and from these sinuses, yellow colored sulfur granules are seen. Now, what are these sulfur granules? Basically, since these granules are yellow in color, they have been compared with sulfur. But originally, these sulfur granules, they represent bacterial colonies. Okay, it is not that sulfur is coming out. Since they are appearing yellowish in color, so, and these colonies are yellowish in color, so they have been compared with sulfur, so they are called as sulfur granules. Now the actinomycosis, the entire disease can be summarized in 5S. The first S stands for swelling. The second S stands for the presence of sinuses, from which the pus is often seen draining out. The third S is for the presence of sulfur granules. What are these sulfur granules? These are bacterial colonies. And the fourth S is these bacterial colonies. This shows sun ray appearance. The bacterial colonies show sun ray appearance. That is why actinomyces is also called as ray fungus. And also this has been compared with cotton wool appearance. The colonies, they either show sun ray appearance or cotton wool appearance. This is histopathological finding. Okay, remember cotton wool appearance radiographically is seen in Paget's disease. Histopathologically, it is seen in actinomycosis. And the fifth is these colonies, they are surrounded by sea of neutrophils, plenty of neutrophils. Okay, so you can summarize the entire disease in 5S. Swelling, that is why it is called as lumpy jaw. Next important bacterial infection is pyogenic granuloma. Rather, this is a mixed infection. This is considered as a reactive lesion which is highly vascular. This is highly vascular. The moment you touch it, it starts bleeding. The most common site, almost exclusively seen on gingiva. 75% of the cases, though it can be seen elsewhere, buccal mucosa, tongue, labial mucosa, but most commonly it is seen on the gingiva. Very commonly seen in pregnant women, mainly in the second trimester. What happens in the second trimester? The hormone progesterone level increases. What does progesterone does? Progesterone basically increases the vascularity. So that means the host response is exaggerated. Okay, so there is increased in the host response. The stimulus is the same. Without any stimulus, without any plaque and calculus, this lesion will not be seen. Stimulus has to be present. The response is exaggerated in presence of the hormone progesterone. That is why it is also called as pregnancy tumor. Very commonly seen in the pregnancy. So it is also called as pregnancy tumor. Okay, now histologically pyogenic granuloma, basically it shows proliferation of numerous capillaries, and these capillaries, they are lined with endothelial cells. Okay, we know that endothelial cells, they form the lining of the capillaries. So these are lined by endothelial cells. Now these capillaries are so numerous that Neville suggested that another name for pyogenic granuloma, histologically it resembles lobulated capillary hemangioma. Okay, he considered this as a type of hemangioma where capillaries are proliferating and it is divided into lobules. This fibrous connective tissue is dividing the pyogenic granuloma into segments. So this is called as lobulated capillary hemangioma. Okay. Now coming on to the viral infections, the first one is herpes simplex. We know that herpes simplex, mainly it is of two types caused by herpes simplex virus 1, that usually involves the skin above the waist, and lesions caused by herpes simplex virus 2 usually involves the skin below waist. Okay, but due to the changed or altered sexual practices, this can be interchanged also. Now either HSV1 or HSV2, mainly this viral infection, the clinical course runs in two stages, that is primary infection and secondary infection. Okay, once this virus enters into the body, it causes the primary lesion. Only in 1% of the cases, 99% of the cases are asymptomatic. Okay, they are asymptomatic. Now either they cause infection or they do not cause infection. 100% of them, they act as carriers. Okay, now what happens after the virus enters into the body? It goes and stays dormant in ganglion. Okay, nerve ganglion. It stays there, can stay there for either for some days, few months, or even for years. It can stay dormant. Okay, and from this ganglion, due to the reactivation, now reactivation can be either a simplest exposure to the sun, or any fever, or any other infection, or any other state which is leading to immunocompromised state, or any trauma, then it will cause secondary infection. Okay, the most common ganglion where it stays dormant is, let us write in the second slide, the ganglion where HSV1 stays dormant. Mainly it is the trigeminal ganglion. It is trigeminal ganglion. Okay. Second preference, this is one. Second preference, it can also go in the nodus ganglion of the vagus nerve. Nodus ganglion of the vagus nerve. Third is it can also go and stay dormant in the dorsal root ganglion. Dorsal root ganglion or the spinal ganglion, and ultimately it can also stay even in brain. It can stay dormant for years even in brain. So this is the order of preference. Choose your answer wisely. Now the primary lesions, primary herpes, it manifests clinically as acute herpetic gingivostomatitis. Acute herpetic gingivostomatitis. Now, the lesions are mainly seen on the gingiva, though it can involve keratinized as well as non-keratinized mucosa. And these lesions, they are usually associated with prodromal symptoms. Patient will give the history of fever, nausea, headache, malaise, weakness. These are prodromal symptoms. Associated cervical lymphadenopathy is also seen. Okay. Now, lesions, they are grayish, they are covered with grayish or yellowish membrane, and there is surrounding red colored halo. Red colored halo, that is important for herpes. Red colored halo erythematous, you could make out in this picture this red colored boundary. Okay, this central area of necrosis which is surrounded by red colored halo. Also in this areas, halo is erythematous periphery. Okay, this is red colored halo surrounding these vesicles. If you touch these vesicles with bare hands, infection can be seen on the fingers, most commonly seen in the dentist. This is called as herpetic whitlow. This is called as herpetic whitlow, commonly seen in the dentist. So it is always advisable to use gloves for examining such patient. Okay. Now after the primary herpes, this virus will go and stay in the ganglion and it becomes dormant over there. The reactivation of this dormant virus causes secondary herpes. Since it mainly involves the vermilion zone or the area surrounding the lips, it is also called as herpes labialis, also called as cold sore or fever blisters. Okay. Now in this also vesicles erupt and there are prodromal symptoms associated with appearance of vesicles also. Now, what are the prodromal symptoms? At the site where these vesicles will appear, before the actual vesicles appears, there is usually itching on that site. Okay, it could be itching, it could be tingling sensation, or even pain, or even burning sensation. And then the vesicles appears usually 1 to 2 days later. These vesicles, they heal in 7 to 10 days and they do not leave any scar behind them. Common differential diagnosis for herpes is aphthous stomatitis. Before that, let us discuss the histopathology of herpes. Histopathologically, they are associated with the formation of intraepithelial vesicles, as shown in this picture. The cells become swollen up. These swollen cells, these are called as Zank cells. And sometimes inclusion bodies are seen in the cells. These inclusion bodies are called as Lipschutz bodies. Okay. These are the important histological findings from herpes. Intraepithelial vesicle formation, Zank cells and Lipschutz bodies. Now what are Zank cells? When the fluid enters into the cell, the nucleus degenerates. It is called as ballooning degeneration of nucleus is seen. Okay, ballooning degeneration of nucleus. And this is the cells, the nucleus becomes pygnotic because it is degenerated now and the surrounding area becomes clear. This is called as clear halo around the nucleus. Okay. Now these Zank cells, they are not pathognomic for herpes because they can also be seen in pemphigus. They can also be seen in varicella zoster, infection caused by varicella zoster virus, that is chickenpox. We will be doing it next, or herpes zoster, and they can be also seen in the infection caused by cytomegalovirus. Okay, so it is not pathognomic for herpes, it can be seen in these conditions as well. Okay, next is important differential diagnosis for herpes, that is aphthous stomatitis, aphthous ulcers. Now, depending upon the size, they can be minor. Most commonly, they are also called as canker sore, or major. If they are larger in size, their size can go beyond 1 centimeter. Another name for major aphthous stomatitis is Sutton's disease. These ulcers, they leave behind a scar upon healing. So it is also called as Mikulicz scarring disease. Okay, they leave behind a scar. And when many small ulcers, herpes lice, around 50 to 100 in number, 50 to 100 herpes-like. This is not true herpes, it is herpes-like, hence it is called as herpetiform. Okay, so these are the three types of recurrent after stomatitis. It could be minor, major, or recurrent herpetiform. Okay. Now, other important findings seen in aphthous, recurrent aphthous stomatitis, there is presence of Anitschko cell. Okay. There is presence of Anitschko cells. These Anitschko cells, again, they are not pathognomic for aphthous because they can be also seen in chronic iron deficiency anemia or megaloblastic anemias, or they can be even seen in patients receiving chemotherapy. Okay, so these cells basically the nucleus shows linear pattern of chromatin. Okay, linear pattern of chromatin is seen. So these are called as Anitschko cells, named after the Russian scientist. Linear pattern of chromatin is seen. Now, the basic difference between herpes and recurrent after stomatitis, as we know that secondary herpes is also called as cold sore, and recurrent after stomatitis minor variant, the most common type is the minor, it is called as canker sore. Okay, this is cold sore, this is canker sore. Mainly secondary herpes or the recurrent type of herpes affects the keratinized mucosa. That is why it is more commonly seen in the lip area or the skin surrounding the lip. So it can involve, most common site is vermilion zone. Okay, basically aphthous mainly involves non-keratinized mucosa. That is, non-keratinized mucosa can be seen on the labial mucosa as shown in this picture, or floor of the mouth, or buccal mucosa. Usually they say that this is attached mucosa and this is movable mucosa. Okay. Now, other important differences in herpes we have done that herpes shows the presence of Zinc cells, whereas in recurrent aphthous what we get to see is Anitschko cells. Okay. Plus, we can find the presence of Lipschutz bodies. These Lipschutz bodies, these are not seen in recurrent aphthous and there is presence of prodromal symptoms, but there is no association of prodromal symptoms as such seen in aphthous. They may or may not be seen, but they are not always seen. So etiology for aphthous, most of the times it is unknown. What they say that it could be either associated with stress or GI upset, or bacteria which are usually isolated from recurrent aphthous could be Staph aureus or even streptococci. Okay, but no definite etiology has been certain till date. Okay. Next is important syndrome associated with aphthous stomatitis, that is Behcet's syndrome. Now, Behcet's syndrome is an important triad for recurrent aphthous stomatitis. Genital lesions, okay, lesions are seen in the genitals, as well as involvement of the eye, whereas uveitis is seen. Uveitis, that is lesions in the eye, genital lesions. So this triad is called as Behcet syndrome. Okay. Another important sign which is seen in Behcet syndrome is Petherji test. Petherji test. Now, what is Petherji test? When we inoculate the skin with normal sterile saline, when we give an injection of the saline, there is a formation of pustule. This is called as cutaneous Petherji test, which is seen in Behcet syndrome. It is positive in Behcet syndrome. Next important syndrome is Reiter syndrome. Basically, Reiter syndrome is associated with reactive arthritis. Reactive arthritis is an important triad of conjunctivitis, non-gonococcal urethritis, and arthritis. If it is associated with mucocutaneous lesions, then we'll call this as Reiter's syndrome. Okay, Reiter is an older terminology. It is not followed these days, but it is associated with reactive arthritis, non-gonococcal urethritis. It is non-gonococcal urethritis and conjunctivitis. Okay, this is Reiter's syndrome. Next is chickenpox, also called as varicella. This is caused by varicella zoster virus. Basically, this is the primary infection. After the primary infection, this virus will go and stay dormant in dorsal spinal ganglion, and then the reactivation. There are no specific oral findings seen in the chickenpox. On the skin, what you could see is the maculopapular eruptions can be seen. Okay, nothing more specific for chickenpox. Now, this reactivation of the virus leads to the secondary infection, which is rather more important for us, that is herpes zoster. Okay, this is because of the reactivation of the varicella zoster virus. Now, this varicella zoster virus, upon reactivation, it involves a specific dermatome. Okay, it involves one dermatome. It never crosses the midline. It never crosses the midline. There are unilateral lesions are seen in an area specific to a particular dermatome. Such a spread is called as zostriform spread. Okay, so what does zostriform spread signifies? It signifies unilateral involvement. Okay, the lesions will never cross the midline unless and until the patient is immunocompromised. If the patient is immunocompromised, then this rule will not apply. Okay. Zoster infection of the geniculate ganglion, it is seen as James Ramsay Hunt syndrome, wherein there is presence of oral lesions, vesicles seen in the oral cavities. See, they are unilateral. Facial paralysis, involvement of the facial nerve causing facial paralysis, and pain in the external ear. Pain in the external ear. This can also be associated with tinnitus, vertigo, okay, involvement of external ear. This is James Ramsay Hunt syndrome. Then is infectious mononucleosis. Important points to be remembered from infectious mononucleosis is it is caused by Epstein-Barr virus. It is also known as glandular fever, also known as Pfeiffer's disease. P is silent. Okay. Important diagnostic test in infectious mononucleosis is monospot test, also called as Paul Bunel test. It's a heterophile antibody test known as Paul Bunel test or monospot test. Mumps, from mumps, basically there is bilateral involvement of the parotid. Rather, the most common viral infection of the parotid gland is mumps. This is caused by paramyxovirus. Paramyxovirus. Important point to be remembered here is complication in adults. It can lead to sterility. It can lead to sterility in adults. These are the important points from mumps. Then is measles. Important point to be remembered from measles. It is also called as morbilli. Okay, morbilliform eruptions are seen on the skin. Maculopapular eruptions are seen on the skin. In the oral cavity, bluish or reddish, okay, flecks are seen or lesions are seen, which are called as Koplik spots. Basically, they are white colored specks, white colored lesions, which are surrounded by erythema, red color. Okay, since they are predominantly white in color, so they have been compared with salt granules or white sand granules. White sand granules. The important part is that these are considered as prodromal sign, which usually disappears once the rashes on the skin appear. Okay, these Koplik spots, they disappear upon the appearance of skin rashes. Okay, appearance of skin rashes. They say that they usually appears 2 days prior to the skin lesions. They appear 2 days prior to the 2 days before the skin lesions appear. 2 days before the skin lesions appear. Okay, so these are called as Koplik spots. Now measles is different from German measles, that is rubella. Rubella is also called as German measles. Okay, whereas measles, another name for measles is rubeola. Okay, rubella is measles, whereas rubella is German measles. This we often get confused. What are German measles are rubella, and measles are rubeola. Now, German measles are different from measles in that there is no Koplik spots seen in them. Another important point in German measles is they are teratogenic. If the mother gets infected with rubella, mainly in the first trimester is considered not safe. The second and third trimester are safe periods. Okay, so if the mother gets infected in the first trimester with this rubella, then the baby is born with congenital defects. Okay, baby can have microcephaly, patent ductus arteriosus, and eye lesions. So baby is born with congenital defects. The second and the third trimester of the pregnancy are counted as safe period. Then is the cytomegalovirus infection of the oral cavity. Mainly it involves the salivary glands. Okay, cytomegalovirus infection involves the salivary glands. No specific oral findings. Important histological finding is presence of Reed-Sternberg cells. These Reed-Sternberg cells can also be seen in Hodgkin's lymphoma. These are characterized by owl's eye image of nucleoli. Owl's eye image or mirror image nucleoli. Okay, so that is Reed-Sternberg cell, also seen in Hodgkin's lymphoma. Also seen in Hodgkin's lymphoma. Okay, next is Kaposi sarcoma. Now, Kaposi sarcoma is associated with human herpes virus type 8, very commonly seen in HIV patients. Rather, it is the most common vascular neoplasm seen in HIV patients. Most common vascular neoplasm seen in HIV patients. Okay. Most common site in the oral cavity, first is palate and the second is gingiva. First is palate and the second is gingiva. दोनों कॉलेज तो मेरा काम हो जाता है, घर पे नहीं होता मेरा काम, तुम वो समझ नहीं रही हो. Next topics are dental caries, pulp and periapical lesion, and diseases of periodontium. Let us take them one by one. So first is dental caries. Now we'll begin with the theories of caries. The most accepted theory for caries is acidogenic theory, also called as Miller's chemico-parasitic theory. Now Miller proposed that caries is taking place because of the primarily two processes. That is, first is demineralization of the inorganic part of the tooth, which is followed by destruction of the organic part. This is followed by destruction of the organic part. He said that since the microorganisms are producing acid, this acid leads to demineralization of the inorganic, which is followed by destruction of. This is the sequence. But the two major contraindications of Miller's theory, he could not explain the concept of arrested caries, as well as he could not explain the initiation of caries on the smooth surface. Okay, smooth surface caries. These were the major drawbacks of the Miller's theory. To overcome these drawbacks, Gottlieb proposed proteolytic theory. He proposed that the initial attack is because of the presence of proteolytic enzymes. These proteolytic enzymes, they attack the organic component first, the organic part of the tooth like lamellae, rod sheath, tufts, and wall of the dentinal tubules are attacked first. But since no such enzymes were found, so this theory was also discarded. Then came the proteolysis chelation theory. It took the common points from both Miller's theory as well as Gottlieb's theory. This was proposed by Schaz and Martin. They came up with a concept of chelation. Now, chelation means complexing of a metal ion to a complex substance through a covalent bond. So in this, the calcium ion is making the covalent bonds with the organic component and it is removing it. It is forming a chelate. So this could explain the caries even at alkaline pH. Okay, acid is not required. With the help of chelation, there can be destruction. But still, the most accepted theory so far, universally accepted theory, is the Miller's theory. Okay, there is no doubt about it. Many researchers still follow the Miller's theory or chemicoparasitic theory. Now, current concepts of caries etiology, it revolves around four parameters, primarily the host factors that involves the saliva factors, the tooth morphology factors, and the immunity that varies from self to self, microbial flora, substrate, and a newly added dimension to it is the time factor. Okay. So what is critical pH? The pH at which any particular saliva ceases to be saturated with calcium and phosphate is known as critical pH. For example, it is in the range of around 5.5 for saliva, and this basically signifies that if the pH goes below 5.5, it decreases below 5.5, then the inorganic component will start dissolving. Okay, so that means if more and more acid is produced, the pH will decrease beyond the capacity of the buffering capacity of the saliva, then the dissolution of inorganic component will begin. The inorganic part will start dissolving. Okay. Then is the microbiological factors. The most important bacteria involved in caries is Streptococcus mutans. Now this is a gram-positive cocci which forms short or medium chains. That is why it is called as cocci. Okay, and it on Mitis celivarius agar they grow as convex colonies. Special important point about Streptococcus mutans is that they require some structure to colonize, so they are not seen prior to the eruption of the teeth. They are not seen prior to the eruption of the teeth. In neonates, the oral cavity of a neonate is sterile. It gets contaminated with the saliva which is introduced with contact or kissing by mother or other relatives or with the utensils. Okay, so it is not seen prior to the eruption of the teeth as well as after extraction of all the teeth. Once all the teeth are exfoliated, after extraction of all the teeth also, this Streptococcus mutans is not seen. Okay. So it is present, it needs some prosthesis or a hard structure to colonize. And what are the special capabilities, special powers present in Streptococcus mutans? The major pathogenic determinants are it has the capacity to rapidly transport the dietary sugars. It has the ability to perform glycolysis at a very rapid rate, and it can tolerate as well as grow at the low pH. The most important, rather the most severe, which is responsible for Streptococcus mutans acting as a pioneer bacteria, is its ability to form polysaccharides intracellularly, intracellular, as well as extracellularly. This is rather more important, polysaccharide synthesis. This bacteria has got enzymes. Because of this enzymes, it can form polysaccharides intracellularly as well as extracellularly. Okay, now how does it do that? Now, S mutants, the major substrate for S mutants is sucrose. The most common form of carbohydrate what we take in our diet is either starch or sucrose. Sucrose is the most common substrate for Streptococcus mutans. In the presence of the enzyme invertase, this sucrose, since it's a dimer, it splits up into the monomers glucose as well as fructose. Now, this bacteria has got an enzyme called as glucosyl S transferase. This is present on the cell wall, and this all the changes are taking place extracellularly, wherein it binds many glucose units together to form large chain polysaccharide called as glucans. Okay. Similarly, in the presence of the enzyme fructosyl S transferase, S stands for synthetic transferase, that is the synthetic activity. It is binding up all the fructose units together to form large chain fructans. Okay. Two types of glucans are dextrans, the homopolymers, or the mutants, whereas one type of fructan is leavens. Now, Out of these, glucans is the one that plays the major role in forming the plaque. Glucans, as the name suggests, they act as a glue, they act as an adhesive. It is the presence of this polysaccharide that enables the colonization of this bacteria. Okay, hence there is formation of plaque, and then the process of demineralization and disintegration takes place. So out of this, the fructans, they are easily fermentable polysaccharides, so they act as an easy source of nutrition to the bacteria. So they act as an easy source of polysaccharides which are easily fermentable. Okay, so even when we are not eating food, when we are not consuming food, these fructans are providing the source of energy to the bacteria. So now once the colonization by Streptococcus mutans have taken place, these Streptococcus mutants, they are called as pioneer bacteria. They are the first one to start the attack. Later on, the lactobacillus, they do not have any such capacity to form polysaccharides. They cannot adhere on their own to the tooth surface, but they can adhere onto the adhesive which is being created by Streptococcus mutans. Now they will come and they will lead to caries progression. Okay, they say that now the gaon bas gaya. Streptococcus mutants have established the colony. Now the lactobacillus will come and they will further aggravate the process of disintegration. So they are mainly responsible for caries progression in dentinal caries. Okay, they lead to the progression of the caries. More and more destruction is seen with lactobacillus. Then the actinomyces, mainly the viscosus, nasalandi or dentaliticus. Most commonly, viscosus is the one which is involved. This produces an acid which has got weak pH. Okay, pH is more such that it can demineralize the cementum. It can demineralize the cementum, but it cannot act upon enamel. So basically, these are responsible for causing root caries. Okay, these are found in root caries. So bacteria for initiation of the caries or pioneer bacteria are Streptococcus mutans. Progression of caries, lactobacillus. Root caries, it is actinomyces. Okay. Then comes the histopathology of caries. At a gross level, we see that if a caries starts in a pit and then it spreads along the DEJ, it forms a triangle wherein the apex is towards the surface and the base is towards the DEJ. This is seen in pit and fissure caries. Okay, this is seen in pit and fissure caries. The shape of the triangle is such that the apex is towards the external surface and the base is towards the DEJ. Whereas in smooth surface caries, this order is opposite. The base of the triangle is towards the external surface, whereas the apex of the triangle formed is towards the DEJ. That means the apex in both these triangles are opposite in direction. This is seen in smooth surface caries. This is seen in smooth surface caries. Okay. Now, talking about histopathology of caries seen in enamel, we divide it into 4 zones. Starting from the deeper zone, that is first is translucent zone facing the dentine. Then we come superficial to dark zone, body of the zone, and last is the surface zone. So let us take them one by one. First is translucent zone. That is the first recognizable zone of alteration seen at the advancing front of the lesion. Most of the times this is not seen, so it is not always present. Okay, it is not always seen. So in translucent zone, they say that the pore volume is barely 1%. The pore volume of normal enamel has got a pore volume of 0.1%. So it increases to 1% in translucent zone. This is followed by dark zone. Now dark zone is also called as positive zone because it shows positive birefringence. Okay, it shows positive birefringence. This is always present. This is always seen. And the pore volume in the dark zone has now increased from 1 to 2 to 4%. The pore volume is increased to 2 to 4%. Next is body of the lesion. This is the area of greatest demineralization, such that the striatum becomes prominent here. This also shows positive birefringence, right? And this the pore volume is seen as 5% at the periphery of this lesion, periphery of the zone, which increases to 25% in the central region. The pore volume increases to 25%. This is the pore volume. Now, the surface zone, this is the most superficial zone. Again, here the pore volume is less than 5%. Okay, pore volume is less than 5%. Just the summary of these four zones: normal enamel pore volume is 0.1%, translucent it is 1, dark zone 2 to 4, body of the lesion is 2 to 5, and surface zone shows less than 5. The amount of mineral loss, maximum mineral loss, is seen in the body of the lesion, that is around 24%. So this is the part which appears as radiolucent. Rest of the layers, they are seen as radio opaque. Okay, so it is only the body of the lesion which appears as radiolucent. That is why the size of the caries, the destruction seen on the radiograph, is smaller as we compare the size clinically. Once we start digging in, we see that the size is bigger because radiographically only one zone is evident, that is body of the lesion. Okay, next is dentinal caries. Next are dentinal caries. In this we can see 5 zones starting from the pulpal surface. The deepest is the zone of patchy degeneration of Tom's fibers. Then comes the zone of dental sclerosis, followed by zone of decalcification of dentine. Then is zone of bacterial invasion, and the most superficial one which is facing the enamel is zone of decomposed dentine. So as per the student, the zone 4 and zone 5, basically this is an area what represents infected dentine. Okay, and the rest of it, mainly these three, this comprised of affected dentine. Okay, now what is the difference between infected and affected dentine? See, infected dentine, that is the zone 4 and zone 5, basically this has got no potential for repair. No potential for repair. Hence, this must be completely removed. It should be not left behind. It should be not left behind during restoration. Otherwise, it might lead to secondary caries. Whereas affected dentine, that is the rest of it, starting from zone 3, zone 2 and zone 1, this still has got some potential for repair, potential for remineralization. The better word is potential for remineralization. Okay? By repair we mean here it is remineralization. Okay? Now, since it has some potential for remineralization, so this can be left behind. This need not be removed during cavity preparation. Okay? Then is sometimes what happens in arrested caries, wherein there are large open occlusal cavities. Once you remove the superficially softened and decalcified dentine, just beneath that you see a very hard dentine. That hard dentine is called as burnished dentine. This is seen associated with arrested caries. This is called as eburnation of dentine. That is, the dentine becomes hard. This is seen when the caries cause an open occlusal cavity. Once you remove the superficially softened decalcified dentine, the dentinal tubules, they are intertangled with each other, similar to the gnarled dentine. The dentine here is getting burnished. Okay, and opposite of this hard dentine is soft teeth or malacotic teeth. This is seen in teeth wherein there are large areas of interglobular dentine. Large areas of interglobular dentine. Okay, we know that interglobular dentine is something which is not mineralized. It is a non-mineralized part. So in such a teeth where there are large areas of interglobular dentine present, this is not normally seen. The spread of caries will be rapid. Caries spread will be rapid because of the lack of mineralized areas. There are large areas of interglobular dentine are seen. This such type of teeth are called as soft teeth or malacotic teeth. Okay. Next is spread of caries seen in primary versus secondary dentine. It has been observed that spread of caries in secondary dentine is slower. This is because slightly the arrangement of the dentinal tubules, this is as per the Schaeffer's, irregularly arranged dentinal tubules. Irregularly arranged dentinal tubules. Okay, the spread of caries in secondary dentine is slower. Now we'll talk about pulp. Next is pulp and periapical lesions. Now, the gist of pulp and periapical lesions, let us try to understand with the help of this animation. First, tooth with infected pulp. That means pulpitis has already taken place. Now, it could be either acute or chronic. It could be reversible or irreversible. Once the infection crosses the pulp, what happens? What are the sequelae of this? The complication of infected pulp. Very rarely, in rarely, bone sclerosis is seen. Okay, rather than bone rarefaction, excessive minerals are deposited in this area and a bone scar is formed. This is called as condensing osteitis. Okay, we will take that a little later again. Most of the times, this periapical inflammation manifests either in the form of periapical granuloma. If the epithelialization takes place, we will call that as periapical cyst. And if there is suppuration in that periapical area, then we'll call it as periapical abscess. Abscess can be again acute or chronic depending upon the duration and the severity. Once the infection from the periapical area spreads and involves the marrow tissue, we say that now osteomyelitis has begun. That is the inflammation of the marrow tissue. It crosses the periosteum and reaches into the tissue spaces. If it is diffuse, we'll call it as cellulitis, and if it is localized, we will call it as abscess. Sometimes direct communication through the formation of sinus is formed from the pulp onto the skin, that is sinus formation, and if the pus is exudated out from that sinus, we call that sinus as parulus. Okay, parulus is nothing but associated with pus. Now let us take some special type of pulpitis. The very first is chronic hyperplastic pulpitis, which is also called as pulp polyp. Why this is special here? Because this is characterized by proliferation of pulp. Okay. Rather than undergoing necrosis, here the pulp is proliferating. That is why the name is. Sorry. Chronic hyperplastic pulpitis. Herein, this is seen in young adults which have got a good immune response and increased vascular supply. Where will you find increased vascular supply? Where the apical foramen is wide. And in which teeth do you find wide apical foramen? Especially your deciduous molars and permanent first molar. So these are the teeth which are commonly involved. So what happens? The pulp, as a response to inflammation, it starts proliferating rather than undergoing necrosis. So it comes up from, this is possible only when there is an open occlusal cavity. Okay, so the pulp can be seen popping up from that occlusal cavity in the form of polyp. That is why it is called as pulp polyp. This is a clinical picture. And histologically, what do you see? There is stratified squamous epithelium covering the inflamed tissue. This is nothing but inflamed pulp. Okay, inflamed tissue is also called as granulation tissue, wherein there are lots of capillaries and lots of endothelial cells. Okay. Now the question comes, since pulp is a loose vascular connective tissue, from where the hell this stratified squamous epithelium has come? I told you that the pulp is proliferating and pulp does not contain any epithelium. So what is the source of this epithelium? This is routinely asked. The sources of the epithelium, it could be implantation of the desquamative cells in the saliva. We know that saliva contains desquamative cells. So such cells are implanted on this pulp polyp and they start proliferating. Similarly, this pulp polyp can be rubbed against the buccal mucosa. The cells from the oral mucosa can be implanted, or the epithelial cells from gingival clavicular fluid can also gets implanted, and then they start proliferating. So this is the source of this stratified squamous epithelium. Okay, so that was the important point about pulp polyp. Next is periapical lesion. First one is periapical abscess, also called as dentoalveolar abscess. Abscess means localized collection of pus. So it is either acute or chronic suppurative process taking place in the periapical region. Acute abscess does not show any significant radiographic findings. Maximum what we can see is increase in the thickness of PDL. PDL thickening can be seen. That's it. Chronic is usually seen in the form of an ill-defined, okay, ill-defined radiolucency. This is what differentiates it from periapical cyst and periapical granuloma. That is, the borders are ill-defined, irregular borders. Whereas in periapical granuloma, this is called as a well-defined radiolucency. Okay, this is well-defined. Basically, this is nothing but a chronic form of periapical or apical periodontitis. This is another name is chronic apical periodontitis. The word granuloma is a misnomer. This is also basically it is an inflamed tissue, so it is a granulation tissue which is wrongly named as granuloma. Since this name has been continued since ages, so nobody is changing that terminology. Otherwise, histologically speaking, it is a granulation tissue. Okay, always and always associated with non-vital tooth. Remember one thing: all these periapical pathologies, periapical abscess, periapical granuloma, as well as the periapical cyst, are associated with non-vital tooth. Okay. Now next is radicular cyst, the most common cyst in the oral cavity. Now, in the granuloma, if epithelialization takes place, okay, if epithelium lining is formed, then we will call it as a radicular cyst. If epithelium lining is formed in granuloma, then we will call it as a cyst. What happens? The rest of molasses, they proliferate under the influence of inflammation. Once they start proliferating, the central cells, they get devoid of the nutrition, so atrophy of the central cells takes place. A lumen is created. Then the cyst expands because of the osmosis, or the fibrinolytic enzymes are released that causes the resorption of the bone and expansion of the cyst. This again manifests as a well-defined radiolucency and always associated with non-vital tooth. Okay, no exception to this non-vital tooth. And histologically speaking, this epithelium lining is arranged in the form of arcading pattern. This we had already done in odontogenic cyst. Okay, what is arcading pattern? So many a times clinicians often do this. They compare radiographically radicular cyst with granuloma. That radiographic distinction should not be done. Sometimes the size may be small and it could be even a cyst. Sometimes the size is big and it could be a granuloma. They say that if the size is less than 2 centimeters, then it is periapical granuloma. If it is more than 5 centimeters, then it is periapical cyst. Technically speaking, this is wrong. The distinction should always be done on the basis of histopathology. If epithelium is present, then it is a cyst. If epithelium is not present, then it is a granuloma. Right? So, to the clinician, this distinction is not of much importance because treatment for both these entities is same, either root canal treatment or extraction. Okay, prognosis is also same. For the clinician, the distinction is of not much importance, but from theoretical point of view, if distinction has to be done, it is to be done only on the basis of epithelial lining. Okay. Then is a special type of osteomyelitis, that is chronic focal sclerosing osteomyelitis. As if the name says, sclerosis is taking place in a focal area, that is deposition of mineral, increase in the mineralization. So these areas appear as periapical radioopacity. Okay, these are also called as condensing osteitis. Condensing osteitis, and it is also known as bone scar. Okay, some of the researchers say that this is just one of the routine findings. This is one of us finding which is seen in the routine radiographs. It is most of the times it is asymptomatic, seen in young adults associated with molars. Important differential diagnosis for chronic focal sclerosing osteomyelitis is cementoblastoma. Now, cementoblastoma is a true neoplasm of cementoblast. Okay, this also appears as periapical radiopaque lesion, periapical radioopacity, but here the radioopacity is fused with the root. The root outline is not seen, whereas in condensing osteitis we could make out the root outline is visible. Root outline is visible. This is how we differentiate cementoblastoma from condensing osteitis. Okay. Then the Gay's osteomyelitis, again a special type of osteomyelitis which is seen in cases where there is mild irritation or mild infection. This is characterized by gross thickening of periosteum and peripheral reactive bone formation. Otherwise, in osteomyelitis, there is bone resorption. Okay, but in this case, bone formation is taking place over the periosteum, that is peripheral reactive bone formation. Layer by layer, bone is added. Layer by layer, bone is formed. Such layer by layer addition of the bone gives radiographically onion skin appearance. Okay, that is the periosteal reaction is seen in the form of onion skin appearance, or onion peel appearance means the same. That is seen in Gay's osteomyelitis. Can also be seen in osteosarcoma. Can also be seen in Ewing sarcoma. Okay, these are the conditions which can show onion skin appearance radiographically. So this completes the periapical. Now the important points from the diseases of the periodontium. First and foremost is the drug-induced gingival enlargement. Commonly involved drugs are calcium channel blockers, for example, nifedipine. Then the immunosuppressants like cyclosporin, or anticonvulsants like phenytoin, very commonly involved, very commonly used drug, phenytoin. So basically what does the drug do? It has been believed that this exacerbates the host response. Okay, stimulus is the same. It does not take place in the absence of plaque. So if plaque is present, gingival growth enlargement is seen because the host response is exacerbated. Then necrotizing ulcerative gingivitis. This previously it was called as acute necrotizing ulcerative gingivitis. Since it is always acute, so this word acute has been removed. This is also called as trench mouth or Vincent's infection. Okay. Now, since this was commonly seen in the people who were involved in the World War, so they were used to stay in the trenches, and this lesion was very much common in those soldiers. So the name has come as trench mouth. Commonly, it is a mixed infection, mainly Bacillus fusiformis, also called as Fusobacterium nucleatum, and spirochete, that is Borrelia vincenti, are involved. Okay, these are the two important bacteria which are involved. Basically, this is, as the name suggests, ulcers along with necrosis. So necrosed areas are seen in the form of grayish pseudomembrane. Okay, there is a formation of pseudomembrane, very painful condition seen in immunocompromised patients or patients who are not taking proper nutrition. Okay, so these ulcers are covered with grayish pseudomembrane. Their management part, detailed part will be dealt again in your perio lecture. Okay. And it starts from interdental papilla. Okay, the lesions usually starts from interdental papilla. The tip is involved. Okay, what do we see on the tip? Usually punched out ulcers are seen which are covered with grayish pseudomembrane. Okay, punched out ulcers are seen. See here, the tip is destroyed. Then it will spread to marginal gingiva, and then it will involve the attached gingiva. Ultimately, it will involve the other parts, leading to ulcerative periodontitis, commonly seen in AIDS HIV patient. If it involves the entire oral cavity, then it will lead to necrotizing ulcerative stomatitis, again seen in AIDS. Okay. Then is desquamative gingivitis. This is purely a clinical term wherein we see that the gingiva is intensely red and undergoes desquamation. Okay. Any lesion in the gingiva which appears bright red in color and is associated with desquamation can fit into this term as desquamative gingivitis. It could be pemphigus, cicatricial pemphigoid, lichen planus, epidermolysis bullosa, SLE, or even linear IgA disease. Mainly these three are the diseases which are primarily responsible for desquamative gingivitis. Pemphigoid, that is the benign mucous membrane type, pemphigus as well as lichen planus. So these were the important points from periodontal diseases. Next are the miscellaneous topics. We are taking them together as physical and chemical injuries, regressive alterations, healing of oral wounds, and spread of oral infection. So let us start with first physical and chemical injuries. So in this first is traumatic cyst, which is also called as solitary bone cyst, hemorrhagic bone cyst. Well, the most accepted theory for its formation is the trauma hemorrhage theory, wherein it says that because of the trauma, there is a formation of clot. The clot breakdowns and leaves behind an empty cavity within the bone. So this empty cavity is not lined by epithelium. Okay, this is not lined by epithelium. Hence, it is a type of a pseudocyst. It is a type of pseudocyst, and upon aspiration, we don't get anything. So upon aspiration, what we get is dry tap. Okay. Now, radiographically, these are seen usually above the inferior alveolar canal. So this is to be differentiated from lingual salivary gland depression of the mandible. That is also called as Stepney cyst, which is seen below the inferior alveolar canal. Okay. This is seen below the inferior alveolar canal, whereas traumatic cyst, as you could see in the radiograph, this is a traumatic cyst. It is seen above the inferior alveolar canal. There is bruxism, also called as night grinding or bruxomania. Some of the researchers say that daytime grinding is bruxomania, night grinding is bruxism, but Schaeffer's use it as a common terminology for both. This is habitual grinding of the teeth. The most common cause are the psychological factors related to anxiety, wherein the situations are tensed or stress. Okay. Then the second most common factor could be localized malocclusion, wherein the patient tries to attain maximum intercuspation and then he develops a habit of biting it or bringing the teeth in that position repeatedly. Okay. Or that could be because of GI upset. Okay, these are the common causes for bruxism. And the effect of bruxism, you know that it could cause atresion in the later stages, but once the patient had undergone bruxism throughout night, in the morning he feels the first sign is the pain at TMJ. Okay, the first clinical sign is pain at TMJ. This is often the first clinical sign. Okay, atresion comes later on. Then is tooth ankylosis. This is submerged teeth. We use the term submerged teeth for ankylosis of the deciduous mandibular second molar. Okay, the most common tooth to undergo ankylosis, deciduous mandibular second molar. Since this is fused with the bone, so it stays there and the permanent molars erupt from behind, as it appears as if the tooth has submerged in the bone. Okay, now clinically, for an ankylosed tooth, if you percuss it, the muffled sound is heard. Rather than normal metallic sound, muffled sound is heard in case of ankylosis. Okay. So this is the clinical picture showing submerged tooth. You could make out the deciduous molar here in the radiograph, right? It has been submerged with respect to the permanent molars. This is nothing but showing clinical as well as radiographic images of submerged tooth. Most common tooth involved is deciduous mandibular second molar. Then is linea alba, that is a white line which is seen at the level of occlusion. Okay, this is seen at the level of occlusion or occlusal table. They say that where the two teeth are meeting together, this is seen exclusively in the area which are where teeth are present, because it is arising from the friction from the surfaces of the teeth. So edentulous areas will not show linea alba, and most of the times it appears as a scallop white line following the morphology of the buccal aspects of the teeth. Okay, this is occlusal level or occlusal table. Then is chronic cheek biting, Morsicatio buccarum. Chronic lip biting is Morsicatio labiorum, and similarly, chronic tongue biting is Morsicatio linguarum. Basically, these are fictitious injuries or the self-induced injuries. Chronic cheek biting, it is commonly seen in people who are involved in glass blowers. Okay, wherein they blow the glass with the pipe to give shapes to the ornaments, glass ornaments. People who are working in the glass factories, their buccal mucosa, there is hypertrophy, and that leads to the chronic cheek biting. Clinically, it manifests as a red and white lesion. Okay, there can be areas because of friction. There are the areas of hyperkeratinization which appears as white, and there can be eroded areas also which appears as erythematous. So it belongs to the category of red and white lesion. This is the picture showing Morsicatio labiorum. Okay, lips are involved, lip biting. Then is Riga fetter disease. That's a special type of traumatic ulcer seen in association with the presence of natal or neonatal teeth. This is usually seen in infants between 1 week to 1 year of life. Okay. Most common site is enteroventral surface of the tongue. Okay. You could see in this picture. This is a traumatic ulcer, and these are either natal or neonatal teeth. Natal teeth means within, they are present at the time of birth, whereas neonatal teeth, they are present within, they erupt within the first month of life. Okay. So the trauma caused by these deciduous teeth or natal teeth onto the ventral surface of the tongue is called as Riga fetter disease. Histopathologically, this Riga fetter disease shows lots of eosinophils. Okay. Plenty of eosinophils are seen. Then is traumatic ulcer. It is also called as decubitus ulcer. Decubitus. Okay, U is missing here. Decubitus ulcer. The most common site is the lateral border of the tongue. These are painful ulcers. Okay, and a cotton roll injury is a type of traumatic ulcer, which is also counted as an iatrogenic injury, wherein you use a dry cotton roll and pull it. So the mucosa is eroded along with that cotton roll, causing a traumatic ulcer. Toe spots is a special name given to the traumatic ulcer caused by denture irritation. This usually develops within a day or two after the insertion of the denture. Okay, if there is any high point, then the patient usually comes with a finger like this. I have got a pain here. Once you remove the denture, what you find beneath that is a sore spot, a type of traumatic ulcer. Chemical injuries, most common, aspirin. Many times, some of the patients, what they do to get rid of the tooth pain or any pain in the oral cavity, what they do for immediate effect, they put in aspirin into that area. Now, aspirin itself being acidic, it is N-acetyl salicylic acid. Okay, so what does it do? It causes necrosis, atrophy in that area. So that white, this area is, this is all dead mucosa. Okay, this is implying all atrophic changes in the mucosa. Extremely painful, and ultimately the mucosa sloughs off. Mucosa sloughs off. This is an example of chemical injury. Other examples, lead poisoning, often called as plumbism. This is associated with peripheral neuritis. This clinically it is seen as a wrist drop or foot drop. This is wrist drop. Okay, and in the oral cavity, grayish or bluish black line of sulfide pigmentation. Lead sulfide is deposited in the areas of inflammation. This is called as Burton or Burtonian line. Okay, both the names are correct. Burton or Burtonian line. Similar bluish black line is also seen in bismuth poisoning. Then other clinical features help us in differentiating between the two. For example, in bismuth poisoning, encephalopathy, hepatorenal impairment, and methemoglobinemia is found, which is not seen in lead poisoning. Then is encephalopathy, hepatorenal impairment, and methemoglobinemia is found, which is not seen in lead poisoning. Then is acrodynia. This is basically resulting due to the chronic mercury exposure seen in children. Chronic mercury exposure, especially seen in children. Also called as pink disease or swift disease, swift fear disease. Okay. The children here will frequently tear their hair out in patches. The one of the clinical sign is you just pull the hair, it will come out in bunches. So as you could see in this picture also, there is a loss of hair patch. That is classical sign for acrodynia, mercury poisoning. Other features, oral manifestations, there can be excessive salivation, ulcerative gingivitis, bruxism, and premature loss of teeth. These are two important signs. Okay. Generally, they say that if these three classical signs are present, then mercury poisoning diagnosis is made easier. That is presence of red, painful, desquamating finger and toes. The skin is desquamating from the fingers and the toes. Neurological symptoms, that is why they also say it as mad as a hatter. Okay. This disease is also called as mad as a hatter because of the neurological symptoms and hypertension. Okay, since mercury was involved in the manufacturing of hats, and those were the ones who were commonly associated with mercury poisoning. Okay, and so these three classical signs, discriminating fingers and the toes, neurological symptoms, and hypertension, this is indicative for mercury poisoning. Okay, or chronic exposure to mercury. Then is regressive alteration of the teeth. Next is regressive alterations of the teeth. Now, these alterations are basically associated with loss of tooth substance. Regression means something is decreasing. Could be physiological or pathological, which is brought about by some foreign agent. So, the changes seen in enamel are atresion, abrasion, erosion, and abfraction. Similarly, in dentine, it could be dentinal sclerosis, formation of dead tracts, or secondary dentine, that is an age-related phenomena. Pulp calcification or reticular atrophy of the pulp. In cementum, there could be hypercementosis or presence of separate calcifications which are called as cementicles. Okay, so important points from atresion. The first clinical manifestation is seen in the form of small polished facet on a cusp tip. That means the cusp tip, it becomes like this. A facet is seen on the cusp tip, or a ridge is formed. That is, a slight flattening of the incisal edge is also seen. Okay, slight flattening of the incisal edge. These are the first clinical manifestations. Then later on, atresion continues and ultimately it leads to the complete loss of enamel, and thereby dentinal sensitivity can also be seen. Abrasion brought about by some foreign element. It could be either people who have got the habit of keeping bobby pins or nails. Notched incisors can be seen here. Okay, we can see a notch here in this picture, or this is because of the bobby pin commonly seen in watchmakers. Or excessive use of floss, this can cause interproximal wear. Okay, or excessive brushing with maximum force. Right-handed brush will have abrasion on the left side of the teeth. Okay, left-sided teeth will be involved. This is cervical abrasion associated with brushing. Okay, when more force is applied than required, then it can cause cervical abrasion. Right-handed person, which teeth will be involved? The teeth on the left side will be commonly involved. Then is erosion. Erosion is because of some chemical substance. Erosion due to the gastric juices. This is called as perimyelitis. Okay, erosion due to gastric juices is called as perimyelitis. Sometimes the entire buccal cusp are lost, and this is replaced by sky slope like depression. It is running from this buccal towards the lingual side. This is sky slope like depression. Okay, covering the entire buccal cusp is lost. Then is abfraction. This is basically due to the tensile as well as compressive forces which are generated during tooth flexure. Okay, a part of the tooth is acting like a fulcrum. Because of this, there is compressive forces are built up, tensile forces are built up in that area, and that leads to the loss of tooth substance. So this is mainly seen in the cervical areas. To differentiate it from cervical abrasion or cervical erosion, these are mainly more deeper, narrower, and V-shaped in contrast to abrasion. It often affects a single tooth with an adjacent unaffected teeth, whereas abrasion and erosion, multiple teeth are involved. Okay, this is a very significant difference. Occasionally, such lesions are subgingival, a site which is typically protected from abrasion and erosion. And one more difference, if there is a restoration present in the cervical third, in abfraction, the restoration is dislodged, whereas in abrasion and erosion, the restoration is not dislodged. It only the surface gets abraded. Okay, this is abfraction, whereas in erosion and abrasion, the restoration is not dislodged. Then is external tooth resorption. Resorption of the tooth from the external surfaces. Many forces can be responsible. Could be periapical inflammation or any forces from neoplasm or some cyst. Okay, as you could make out in this picture, could be most commonly they are seen either in the periapical area, could be seen in the cervical third as well. Okay. More important is internal resorption of the teeth, which is also called as odontoclostoma or pink tooth of Murmury. This is to be differentiated from pink disease that is associated with mercury. Okay. Now, since this is odontoclastoma, lots of odontoclasts are proliferating and they are resorbing the dentine from the inner side, and the pulp is proliferating. Okay, there is basically pulpal hyperplasia. Pulp is proliferating in an intact tooth. That is why the red color is reflected as pink. It is called as pink tooth of Murmury. Okay? Radiographically, enlarged pulp chambers are seen. Look at this. Enlarged pulp chambers can be seen in internal resorption. Then is healing of oral wounds. In this, there is an important topic, that is exfoliative cytology. This is nothing but the study of cells which normally exfoliate or abrade from the body surfaces. We know that from the stratum basalis, the cells reaches into spinosum, granulosum and corneum, and ultimately they are shed off. So we are just collecting the cells which are shed off. If there is something wrong, then the rate of shedding and the morphology of the cells will be different. So we classify this cells as we see. If all the cells are normal, we say that this is class 1 cytosmear. Class 2 means some cells shows atypia, minor atypia is seen. Class 3 is in between atypical features. Some of the cells will show atypia, but majority of the cells will be normal. So that is called as indeterminate. That means biopsy is recommended. In class 4 is suggestive of cancer. There are lot many cells which shows cellular atypia, which shows dysplastic features. So biopsy is mandatory. And class 5, almost all the cells shows atypia. Again, the biopsy is mandatory. Okay. So for class 4 and class 5 cytosmear, biopsy is mandatory. Whereas for class 3, the biopsy is recommended. Okay, it depends upon the clinician. Clinician will assess other clinical parameters and then will take a final call. This exfoliative cytology, it acts as a screening test. It is not a definitive test. The gold standard for diagnosis is still the histopathological examination. Okay, the biopsy. The histopathological examination or the biopsy is still the gold standard for diagnosing. Okay. Most common stain used for exfoliative cytology is Pap stain, Papinocola stain. In short, we call it as Pap stain. This exfoliative cytology is an old concept. Recently, what we do is brush biopsy, where we use a cytobrush. Okay. What is cytobrush doing? Cytobrush, rather than collecting the cells which are normally exfoliated, we are scraping it. Okay. The cells are scraped. The tissue is scraped such that even bleeding is seen from the superficial surface. With the help of this brush, the tissue is scraped. The better advantage is that we get all the layers. So this is called as transepithelial biopsy. Okay. The deeper layers, basal cell layers, are also collected. Basal cell layers are also collected in this. So this is an advantage over the exfoliative cytology, which is not transepithelial. In exfoliative, we are just collecting the superficial cells, wherein the deeper cells are collected in brush biopsy. Okay. Once we collect the smear and we assess it with the help of the software that is called as oral CDX. Okay. That's the name of the software that we use in for assessing such smears. Okay. Next is healing of extraction wound. The healing, we have divided the changes into 4 weeks. The first week, as there is a formation of the clot begins to undergo organization. Second week is the when the epithelialization is completed in the smaller sockets, but still the larger sockets epithelialization is going on. By the third week, clot is completely organized by maturing granulation tissue. Okay, complete organization of the clot is seen in third week. And the formation of the bone, trabeculae of osteoid, they are seen around the socket wall, that is in fourth week. Okay, formation of the trabeculae, they start appearing in the third week, but the complete bone formation continues in the fourth week and in the weeks coming beyond that. Okay, so if somebody asks first appearance of the trabeculae, that will be in the third week. First appearance of bone is seen in third week. From third week onwards, it continues in the fourth week, wherein the bone filling the alveolar socket continues, and it goes to fifth, sixth, seventh, eighth week. They say that for the bone to become radiographically evident, it takes a minimum time period of 6 to 8 weeks after the tooth extraction. Okay, so first evidence of bone is seen in third week. Okay, and this continues from third week onwards till around 2 months post extraction. 2 months post extraction. They say that even after 2 months, you can make out that this is extraction socket and this is the normal bone. Okay. Then is spread of oral infection. Important lesion in this is cellulitis. We know that the generalized space infection is cellulitis, localized is abscess. So most common microorganisms, the enzymes what they produce are responsible for causing diffuse spread of infection. Enzymes involved are streptokinase, hyaluronidase and fibrinolysin. Most common bacteria involved is streptococci because of its ability to produce this enzyme hyaluronidase. Okay. Prevotella and Porphyromonas species, they are responsible for destroying the collagen. Okay, they have the enzymes that destroy the collagen. Then is Ludwig's angina. Ludwig's angina is nothing but the bilateral involvement of the three spaces. Again, you would have done in oral surgery in much more detail. That is sublingual, submental, and submandibular space. When all these three spaces are involved bilaterally, we'll call that condition as Ludwig's angina. Most common tooth involved is mandibular, second and third molar. Why? Because the apices of these teeth are situated below the mylohyoid ridge. Hence, they cause infection of the submandibular space. Okay, first molar, the apices are present above the mylohyoid ridge. Above the mylohyoid ridge. Okay, so it involves usually the sublingual space. Submandibular space is not involved with first mandibular molar very often. Okay, though later on it involves, all these spaces are connected, but initially the most common teeth involved in Ludwig's angina are second and third molar. Could be either because of periapical pathologies or periodontal pathologies. Both can cause Ludwig's angina. Again, the most common bacteria involved are streptococci, which are invariably present. Other bacteria like fusiform bacilli, spirochetes, staph aureus, prevotella, and even diphtheroid bacteria are also found. Then the last term from this to distinguish the two terms, focal infection and focus of infection. See, focal infection is localized or general infection which is caused by dissemination of microorganisms or toxic products from a focus infection. In layman language, what you say, infection is nothing but a focal infection. From where does the infection spreads? That focus, that circumscribed area of the tissue which is infected with exogenous pathogenic microorganisms is called as focus of infection. Means this is usually an area where microorganisms are present in plenty, closer to the surface. From this surface, now the infection will spread to the rest of the part. Then we say that the infection has manifested. Okay. So common oral foci of infections, they are mainly the periapical or periodontal pathologies, and they are associated with many systemic diseases like subacute bacterial endocarditis, rheumatoid arthritis, and many other GI and renal problems are also associated. Okay, wherein the infection from the oral cavity can exacerbate these systemic conditions. Okay, so these were the important points from this chapter.